I welcome you all, along with my co-chairperson, Dr. Sangeeta Gupta, to a webinar under the aegis of AOGD Fetal Medicine and Genetics Subcommittee. And the topic for today's discussion is the Fetal Anomalies Workshop, Meeting the Expectations. First of all, I would extend my heartiest welcome to both our chief guests, the guest of honor, and the expert for the today's session. Next. Yes, it's my pleasure to introduce Dr. Madhuritu Banerjee, who is currently working as a HOD and senior advisor at Venkateshwara Hospital, Delhi. She is a graduate and postgraduate from AFMC Pune, and she has an illustrious career for serving the Indian Navy as a specialist in radio diagnosis for 20 years, with postings to Navy Hospital in Port Blair, Mumbai, Visakhapatnam. She has also worked at AFMC Pune, R&R Hospital, and Base Hospital, Delhi. And she has received President's Gold Medal for standing first in MBBS. And she has ranked third in the Pune University MD Radio Diagnosis. And she has been awarded a State Award, Lieutenant General's Award in the Union Territory of Port Blair for exceptional contribution to the field of medicine and dedication to the duty. She is a member of IRIA and has presented several papers and chaired sessions at various conferences. I welcome you, ma'am. Next, please. Now, our second chief guest for today's session is Dr. Monica Bhatia, who is a senior consultant and HOD of the Obs and Gynae department at Venkateshwara Hospital. She has done her MBBS from KMC Chennai, and she has done her DCH from MAMC Delhi and MS from LHMC Delhi. She has also done diploma in ultrasound, and she is MRCOG gold medalist from UK. And she is currently she is also a DNB trainee at Venkateshwara Hospital. She has been awarded Dr. Vijay Patil Gold Medal in MRCOG and Dr. K. Baliga Gold Medal for Best Senior Resident at LHMC. She has worked as an assistant professor at LHMC and SGT Medical College and as deputy commandant at CAPF Base Hospital, New Delhi. And she has got many publications and has been a speaker in multiple conferences. She has a keen interest in academics, laparoscopy, infertility, and high-risk pregnancy. Welcome, ma'am. Next slide. It's my honor to introduce Professor Achla Batra, who actually does not know much introduction, but she is currently working as Department of Obs and Gynecology at VMMC and Safdarjung Hospital, New Delhi. She is currently the President of AOGD and President Narchi Delhi Chapter 2018 to 20, Chairperson Urogynecology Committee AOGD 2009 to 11, Chairperson Rural Health Committee AOGD 2017 to 19, Honorary Secretary AOGD 2015 to 16, Ex-Editor AOGD, Ex-Editor Narchi, Coordinator of Foxy Critical Care Conference 2016, UA Foxy North Zone 2018, and dedicated PG and undergraduate teacher for past 35 years. She has conducted research projects for LSTM, ICMR, and Indo-US projects, and author of workbook of obstetrics, CBS publication, and contributed several chapters in books, and authored several original research papers in international and national journals, reviewer in national journals, and contributed to several MOH, Ministry of Health and Family Welfare guidelines. Welcome you, ma'am. Now I request my co-chairperson, Dr. Sangeeta Gupta, to introduce the expert for the session today. Dr. Vandana Chadda. Dr. Sangeeta, are you around?
Yeah, good afternoon, everybody. And the first introduction for Dr. Vandana Chadda is that she's a dear friend and she has a lot of laurels to her credit. She's a very astute clinician and we often seek her opinion in the field of fetal medicine. A certified medical geneticist from SGPGI postdoc fellowship in maternal fetal medicine from University of Toronto. And she's running a very, her own center of fetal and genetic medicine known as Sattva Fetal Care at New Delhi. Her main areas of interest are imaging, fetal interventions, therapy, multiple pregnancy, fetal genetics, and autopsy. And she has received many honors, many awards, has multiple publications. And one of her major achievements is that she had set up the fetal medicine unit way back in 2005 at Moolchand. And with that, I request Dr. Vandana Chadda I welcome her, and we'll be looking forward for her expert comments all through the session.
Welcome, Dr. Vandana Chadha, and thank you, Dr. Sangeeta. So now we begin with the workshop today. So in the past few years, the introduction of non-invasive prenatal testing with cell-free fetal DNA has expanded the original role of the 11 to 13-week NT screening for chromosomal abnormalities. And concomitantly, the anatomical examination of the fetus is moving from the mid-trimester to the early gestation anomaly scan. Role of fetal ultrasound is evolving very fast. When the first trimester ultrasound was initially introduced, it had the purpose of determining the fetal viability, measuring the CRL, or to achieve the accurate pregnancy dating, and to define the fetal number and the chorionicity. But the study of anatomy of the fetus was confined in the second trimester of the pregnancy. Over the past 30 years, the assessment of the fetal anomaly and therefore the diagnosis of the malformations has moved progressively from the second to the first trimester. And this is mainly attributed to the two factors, the high resolution ultrasounds and the improving skill of the fetal medicine specialist or the radiologist working in this area. And sensitivity of the first trimester scan to pick up the anomalies is about 50% overall, and 40% in the low risk population and 60% in the high risk population. But the new challenges should focus on developing an updated approach to maximize the detection of the fetal anomaly. So with this, we move on to our workshop. In today's workshop, we have covered routine first trimester diagnosis, counseling for the common abnormalities, genetic tests in the cases of the fetal abnormalities. We will also be discussing about the discordant abnormalities in the twin pregnancy. We have a session on counseling for fetal cardiac abnormalities and postnatal surgery for the correctable fetal abnormalities. And finally, we'll be discussing about the fetal surgery, the new excitement. Now we begin with our first session, and I request Shivam to give me the. So the chairpersons for the first session, Dr. Meenal Chaudhary, and everybody knows her. She is working at Akash Hospital as an HOD radio diagnosis. Next, please. Now I invite Dr. Onam Khattar. She is working as a consultant Obs-Gynae Gynae at Venkateshwara Hospital. She is an MBBS from SMS Medical College, Jaipur, and post-graduation from Municipal Medical College, Ahmedabad. And she has done her senior residency in Manipal, Karnataka. And she's a lifetime member of FOXY, AOGD, IMS, and her areas of interest is high-risk obstetrics and infertility. Welcome, ma'am. Next, I invite Dr. Madhulika Sinha. She is working as a senior consultant and unit head Obs-Gynae Gynae at Akash Healthcare Super Specialty Hospital, Dwarka. She is a life member of FOXY and IMA, an alumni of BHU IMS, and achievements and awards. She is a recipient of IMS BHU Gold Medal and Dr. S.N. Malhotra Award for Best Paper in Infertility in UA FOXY Conference, and first prize for Best Paper Presentation in AOGD. And her special interest is infertility and high-risk pregnancy. Welcome, Dr. Madhulika. Now I request the chairpersons to introduce our first speaker. Shivam. And Dr. Madhulika, are you there? Okay, so I think.
Shall I take it? Hi, this is Dr. Meenal. Dr. Madhulika, are you there?
Yes.
Yeah.
Can you hear me?
Yeah, now.
Yes.
Please
Am I
go on.
audible?
Yes.
Yes.
Loud and clear.
It's a pleasure to introduce the first speaker of today, Dr. Sabitha. She is a graduate from Lady Hardinge Medical College and a postgraduate from Maulana Azad Medical College. She was an ex-consultant at BL Kapoor Hospital, and she has done her fellowship in fetal medicine from Apollo Hospital, Delhi. And she's accredited by Fetal Medicine Foundation, UK. She is presently working at Venkateshwar Hospital at Dwarka, and her main area of interest is management of high-risk pregnancies, screening and diagnosis of fetal abnormalities as early as first trimester, fetal interventions and therapy, and she believes in affordable, sustainable, and quality care for all. So welcome, Dr. Sabitha, as the first speaker, and we are eagerly waiting to listen to you.
Thank you, ma'am. Thank you very much for the introduction.
Full screen. Yes.
Good afternoon, everyone. I welcome you all to today's online webinar. I'll be discussing about the approach to first trimester anomaly scan. So we are very thankful and grateful to Professor Kipros, who has introduced this idea of inverted care of pyramid, and first trimester anomaly scan is a step ahead in that direction. As you all know, the aim of first trimester scan is dating, risk calculation for aneuploidies, risk calculation for preeclampsia, risk calculation of a preterm delivery. And today we are going to discuss an important component of the first trimester scan, that is evaluation for the structural abnormalities. So there are a lot of advantages of doing an early anatomic survey in the first trimester. There's an early detection and exclusion of major abnormalities, gives early reassurance to the mother. And also, if in case of abnormalities, early genetic diagnosis is required, that can be offered to the couple. And if early termination is required, that can be offered to the couple. Also, and first trimester, there is lack of bony ossification. So the obstruction of views is not there. The fetus are highly mobile, so we can see the fetus from different angles. And currently, with advancement in machine and technology, the views are becoming amazing day by day. There are certain challenges which we face with the first trimester anatomic survey. First is to need to combine a transabdominal and transvaginal approach, which might not be acceptable to certain patients. Also, the small size of the fetus and small size of the fetal organs. Certain markers are not seen at the time of first trimester. They are certain pathologies which evolve into second and third trimester. They cannot be picked at this time. Also, we require trained people and experienced people who can pick up anomalies in first trimester. Also, there is uncertain cost to benefit ratio. There are four main protocols or pathways on which we can detect anomalies in first trimester. First is a major malformations, which are very clearly visible on the scan, which includes early hydronephrosis, alobar leukoencephaly, large omphalocele, megacystitis. On a routine scan, when we see a thick NT is a marker not only for aneuploidies, but is also a marker for detecting abnormalities. There's a whole list of congenital malformations which are associated with thick NT. So whenever we see a thick NT on the scan, we have to look the baby in fetus to pick up associated abnormalities. Also, certain pregnancies are at high risk of malformation. So we have to take a detailed history from the patient about the previous pregnancy and the family history. For example, if there's a prior history of spina bifida, or there's a history of autosomal recessive syndromes of inheritance, like Michael-Gruber syndrome, which has a pattern of inheritance, where there's a 25% chances of recurrence in the next pregnancy. Also, we can pick up anomalies on a routine first trimester low-risk pregnancy. This is a list of anomalies A to Z, which are associated with the fetal malformations, which are associated with thick NT, anomalies of CNS, head and neck, thoracic and abdominal anomalies, skeletal dysplasias, a lot of genetic and metabolic syndromes, the huge list of anomalies associated with thick NT. So this is a protocol which has been suggested by the ESOG for the 11 to 13 week scans, and from head to toe, this is a list which we can, which are we supposed to check, and the structures marked in A are optional. So like in head and brain, we have to look at the cranial bones are present, look at the normal ossification of bones, look at the midline arcs, look at the bilateral cortex filling the ventricle. When we go to the neck, look at the normal appearance of the neck, look at the nuchal translucency. Then in the face, we have to look at the eyes, and we have to look at the intraocular lens, look at the nasal bone, normal profile of the face, intact lips. In spine, look for the overlying skin is intact and look at the vertical column in the longitudinal and axial view. In the chest, look at the bilateral lungs. In the cardiac, confirm the situs, rate, rhythm, four-chamber view, three-vessel view. In the abdomen, look for the stomach bubble is present. Look for the cord insertion. In the extremities, we have to document all three segments of both upper and lower limb. Placenta, look at the size and texture. In the cord, look for three-vessel cord. So this is a list of anomalies which is 100% detectable in hands of expert and should be picked up by the end of the session by everyone. So these anomalies have a 100% pickup: early hydrops, anencephaly, lobar prosopolencephaly, body stalk anomaly, ectopia cordis, large omphalocele, large gastrorisis, large megacystitis, and molar placenta. There are certain anomalies which are potentially detectable in first trimester, but they can be missed at the time of first trimester. They have a lot of indirect signs for picking up these at the first trimester. The potentially detectable ones are open spina bifida, ventriculomegaly, facial clefts, diaphragmatic hernia, cardiac anomalies, polycystic kidneys, lethal skeletal dysplasia, short long bones, absent hand and foot, and polydactyly. Falling anomalies are not detectable at the time of 11 to 13 week scans because these are evolving pathologies and they usually present themselves in second to third trimester, like microcephaly, the third trimester, craniosynostosis is third trimester, agenesis can be picked up in the second and third trimester, CPAM is picked in second and third trimester, and these anomalies are picked in second and third trimester and will not be picked at the time of the first trimester scan. So this is a table depicting what is the percentages of various anomalies picked. As we see, acronia is 100%, open spina bifida is 14%, omphalocele is 100%, lethal skeletal dysplasia is around 50%. So various percentages are shown in this particular table. Now let's start with the approach towards the first trimester anomaly scan. First of all, we start with the general overview and biometry. Look at the location of the sac, look at the cardiac activity of fetus, number of fetuses, location of the placenta in relation to cervix, any subchorionic bleed, and fetal biometry. In the fetal biometry, we will measure the CRL, we'll measure BPD, HC, AC, FL. Now, first step is to take the anterior mid-sagittal section of the plane of the fetus. Now, this is an ideal plane for measuring the CRL from crown to rump. Also, look at the head, look at the normal frontal physiological bossing, look at the nasal bone, look at the maxilla and the mandible, look at the neck, look at the chest, heart, stomach bubble, cord insertion, bladder. So this single plane gives us a lot of crucial information. Folly anomalies can be picked in the mid-sagittal CRL plane, which is hydrops, anencephaly, holoprosencephaly, body stalk anomaly, ectopia cordis, omphalocele, gastroschisis, megacystitis, and molar placenta. Now, this particular mid-sagittal plane of the face, we are all aware, this is an ideal plane which we require for the measurement of ND. Apart from the nuchal translucency, this plane gives us a lot of important information about the head and neck and the face. So for the face, look at the normal physiological bossing, look at the nasal bone, which is seen as an equal to sign, look at the maxilla, look for any mind the gap in the maxilla, which is an early sign for the cleft palate. Look at the mandible and look at the normal facial profile. Is there any retrognathia, micrognathia, excessive bossing? Now this is the brain. We will look at the brain. This is the thalamus and the brainstem. Behind the brainstem is our fourth ventricle or IT. IT, as we know, is a marker for increased IT is a marker of the posterior fossa anomalies, and collapsed IT is a marker for neural tube defect. Behind the fourth ventricle is the choroid of the fourth ventricle. This is the cisterna magna, occipital bone, and this is the nuchal translucency. Next, we move on to the various axial planes of the head and neck, thorax, abdomen. First of all, I'll cover the axial planes of the brain. So as we move from up to down, I have taken 4 axial planes in the brain. In plane number 1, look at the normal ossification of the skull. Then look at the midline falx and look at the symmetrical choroid plex. Look at the bilateral choroid plexus. Normally, the choroid plex fill more than 50% of the ventricles. These are the lateral ventricles. And if the choroid plexus occupy more than the 70 to 80%, then we have to suspect neural tube defect. And if the choroid plex are filled in less than the 50%, we have to suspect ventriculomegaly. Between the choroid plex, here is the third ventricle. As we move more down in this plane, we see these are the thalami, and this is the aqueduct of Sylvius. And on the sides of the aqueduct of Sylvius are the cerebral peduncles. Now, this is also a very important plane because in the neural tube defect, there is a posterior shift of the aqueduct and the cerebral peduncle, and this space gets obliterated, which is also seen as collapsed IT in our mid-sagittal plane. Now I go on to third plane. As we go lower down, we can see the developing cerebellum. We can see the IT is communicating with the cisterna magna, and this is the normal choroid plex of the fourth ventricle. In case of posterior fossa anomaly, this hourglass shape is missing, and the choroid plexus are absent, and this place will be widened. So when we are seeing wide posterior fossa in first trimester, we have to suspect posterior fossa abnormalities and call patient for an early level 2 at 16 to 17 weeks. The fourth axial plane is at the level of the orbits. We can see both the orbits. Look for the intraocular lens. We can suspect an ophthalmia or congenital cataract in this plane. These are the maxillary process of the maxilla and nasal bone. The fourth plane is the cornal section of the face. Face we have seen in two sections. One is the sagittal, which I have previously discussed, and this is the cornal plane of the face, also known as the retronasal triangle of the face. So look at both the nasal bones and look at the both the orbits, intraocular lens, maxillary process of the maxilla. This is the alveolar ridge of the maxilla, and this is the mandible. This mandibular gap is a normal physiological gap which is routinely seen in all the fetuses at this point. If the mandibular gap is absent, then we have to suspect retrognathia or micrognathia. Now, a few cases I'll be discussing. Acronia, as we know, it's 100% detectable at the time of first trimester scan. Acronia, there's an irregular amorphous brain which is there, and the skull bones are absent. Also described as Mickey Mouse sign. On TVS, the amniotic fluid appears turbid. The CRL, when we measure, is smaller than the gestation. Acronia can be an isolated finding, or it can be associated with other structural abnormalities. When it is associated with other structural abnormalities, then we have to suspect aneuploidies. Also, acronia can be a part of amniotic band syndrome. Now, this is a case of occipital encephalocele. Occipital encephalocele is a part of neural tube defects, and occipital encephalocele is a bony defect in the posterior part of the occiput. Encephaloceles can be frontoethmoid, occipital, or lateral. The most common type is the occipital type. The lateral encephaloceles are usually associated with the amniotic band syndrome. The midline encephaloceles are usually associated with the band syndrome. When we see occipital encephalocele, we have to look at the baby in detail, because if there are associated abnormalities, then the risk of syndromes increases. For like in the Meckel-Gruber syndrome, there's an occipital encephalocele with polydactyly and polycystic kidney. And Meckel-Gruber is an autosomal recessive syndrome, and it has a 25% chances of inheritance. I'm covering neural tube defects here because there are a lot of intracranial signs which we see in the first trimester neural tube defects. So I will be covering open neural tube defects here. So this is a picture of a normal baby at 12 to 5 weeks. We can see the normal physiological bossing equal to sign for the nasal bone. This is our thalamus, midbrain, brainstem, and this is the normal IT. And this is the choroid plex of the fourth ventricle. This is our cisterna magna, occipital bone, and this is the nuchal translucency measure. Now, in this case, the IT is collapsed, the brainstem is widened, there's a posterior shift of the brain. Also, when we measure the BPD, in case of an open neural tube defect, the BPD is short, is small, and also we can see the choroid plexus are practically filling the lateral ventricle. I could demonstrate the open neural tube defect in this case. Sometimes it might not be visible. So when it is not visible, then we have to call the patient for early level 2 at around 15 weeks. And at 15, we'll be able to demonstrate all the intracranial signs. So this is the post-abortal picture of this fetus, because we could demonstrate at 12 to 15 weeks. So we aborted the fetus. So I have discussed all the features which we have to look for open neural tube defect in the axial planes of the brain. So open neural tube defect can be an isolated finding, and it can be associated with other syndromes. So when it is associated with other syndromes, we will find multiple abnormalities. It can be seen in cases of trisomy 18 and triploidies. This is a picture of a holoprosencephaly. Holoprosencephaly is a cleavaging defect in the brain. Here we can see the midline fox is absent. The ventricle, the lateral ventricle, there's a single monoventricle which is crescent shaped, and the thalmi are fused. Holoprosencephaly are of 3 types. It is alobar, semi-lobar, and lobar. The most common severe form is alobar and alobar. In this case, we offered, baby also had multiple abnormalities like bilateral cleft and polydactyly. CVS was done. It was a case of trisomy 13. So a holoprosencephaly can be an isolated finding, or when it is associated with abnormalities, there's an increased chance of especially trisomy 13. It can be seen in trisomy 18 and triploidy. It can be part of autosomal recessive syndromes. Also, it can be seen in autosomal dominant non-syndromic holoprosencephaly. There is a list of 14 genes which are associated with the holoprosencephaly. Now, this is from the same fetus, the previous fetus. The baby had holoprosencephaly, polydactyly, and it also had a bilateral cleft. So we can see the bilateral cleft, and this is the post-abortal picture of the bilateral cleft. Now we move on to chest and heart. So the first step in the evaluation of the fetal heart is to confirm the situs. To confirm the situs, we have to take the axial view in the upper part of the abdomen, and we'll demonstrate the stomach on the left-hand side. Then we move up in the chest and confirm the situs. Look at the cardiac axis. The normal cardiac axis is 45 degree plus minus 8 degree. In 75% of the major CHD, cardiac axis will be deviated. And whenever we see thick anti-tricuspid regurgitation, ductus venosus A-wave reversal, we have to suspect the congenital cardiac anomalies. So first pain we took at the level of the abdomen to confirm our situs. As we move up, we come to the 4-chamber view, and then we come to the 3-vessel trachea. In the 4-chamber view, we'll demonstrate both the grayscale and the color. In the grayscale, we see bilateral lungs. We look normal. Look at the ribs. Then this is the descending aorta, which is behind the left ventricle, and we can see all the 4 chambers of the heart. We can measure the axis. Routinely, I don't measure the axis, but I do eyeballing, and whenever I suspect an abnormality, I do measure axis. So axis looks normal. We put in color, and we see equal amount of filling of both the side of the heart. Now we move on to 3-vessel trachea view. This is the trachea, aortic arch, and the superior vena cava. They are both seen on the left side of the trachea, and when we put in color, they form a V or a tick sign, and we see concordant blood in both sides of the both the aorta and the superior vena cava. I'll be discussing 2 short cases which I picked up in first trimester. This is normal picture of the normal heart, stomach on the left, equal amount of blood flowing to both the sides of the heart, concordant blood flow. This is 4-chamber view, and this is a 3-vessel trachea view for the tick sign. Now I move on to case number 1. This patient was referred to me in view of reversal of A-wave in the ductus venosus. Also, baby had thick anti. So I did further evaluation. On the gray scale, the situs was fine. Heart looked a little bigger to me, and the ventricles appeared to be a monoventricle. On putting the color, I could see there was a blood flowing from the left atrium to the left ventricle, and the blood flow on the right sides were in the opposite direction. On the 3-vessel trachea view, there was a single large vessel. So most likely, in this case, there is a large VSD, which is across which there is a flow from the left ventricle to right ventricle, and this is because of the tricuspid atresia. Because of the tricuspid atresia, there was no flow from the right atrium to the right ventricle, and there was a recurrent flow across the VSD, and also there was pulmonary atresia. That is why there was a single vessel in the 3-vessel trachea view. Whenever we see major congenital abnormalities, we have to look for other abnormalities. We have to offer invasive testing. As we know, major cardiac abnormalities are associated with the aneuploidies and 22q deletion. This is the next case. This was referred to in view of thick anti and absent nasal bone. And when I looked at the heart, the axis looked deviated. I measured the axis. It was nearly 79 to 80 degree. And on further evaluation, I saw there was an aorta which was overriding both the ventricles, and there was a VSD, and this could be demonstrated in color also. So this is a tetralogy of Fallot. As we know, tetralogy of Fallot has 4 components. It has a large VSD, an aorta overriding the VSD, and there is pulmonary stenosis, and there is hypertrophy of the right ventricle, which cannot be demonstrated antenatally. So these 3 components can be demonstrated. CVS was done in this case. It was a case of trisomy 21. And TOF is known to be associated with the major genetic abnormalities, and it is one of the major cyanotic heart disease postnatally. Now we go on to abdomen and pelvis. We'll be taking 3 axial planes in abdomen, upper abdomen, middle abdomen, and lower abdomen. In the upper abdomen axial plane, we have to demonstrate the left-sided stomach, and we have to demonstrate the umbilical vein. Then as we go lower down, we look at the normal cord insertion to rule out the abdominal wall defects. And in third plane at the level of the pelvis, we demonstrate the bladder, we put in color and demonstrate the 2 umbilical arteries of the umbilical cord bifurcating at the level of bladder. Now we take 2 coronal planes. One is of the fetal chest and abdomen. In this, we can show the bilateral lungs. We can see the ribs and we can see the stomach bubble below the diaphragm. This view is important in demonstrating major diaphragmatic hernias. Next, we take a coronal view of the posterior abdomen. We can see the midline spine. We can see both the kidneys. If we put in color, we can see the bilateral renal arteries bifurcating from the aorta. We can see the ribs. We can see the pelvic bones. Now, this is a normal picture of a cord insertion. And this is when we put in color at the level of bladder. We see the 2 umbilical arteries bifurcating at the level of bladder. In this case, we see a single umbilical artery. Single umbilical artery can be an isolated finding, or it can be associated with various syndromes like trisomy 13, 18. If it's an isolated finding, then there's a risk of FGR. And if it is associated with other syndromes, then it can be seen in trisomy 13, 18, and other aneuploids. Now, this is a picture of an exomphalos. Exomphalos is the herniation of the abdominal content into the sac, and there's a cord insertion at the top of the sac. Now, an exomphalos is there's 60% chances of major chromosomal defects, especially with trisomy 18 and 18. It can be seen with 13 and 21 also. The risk of aneuploidy increases if there's only if the sac only contains the bowel rather than the liver. And in the exomphalos associated with thick anti, there's 5% chances of aneuploidy. Now, these are the normal kidneys. We can see the normal kidneys. A color Doppler was put. We can see the normal bifurcation of the renal arteries. Now, this is a case of megacystitis. So, megacystitis is defined as when the bladder measures more than the 7 mm in the sagittal plane. And to confirm whether this is bladder or not, we have to put in our color, and we can see the umbilical artery, which divides at the level of the bladder. So in this case, the bladder was 21 mm, and we could see the kidney, the pelvis looked a little dilated. The kidneys looked echogenic. The CVS was done. The chromosomes were normal, and we followed the baby at 16 to 16 weeks, and there was absent liquor, and there was couple decided, and we offered the couple to terminate, and they terminated. So megacystitis, as I told you, is longitudinal diameter more than 7 mm. When it is between 17 to 15 mm, there's 20% chances of chromosomal defect, especially 13 and 18. If the bladder is between 17 to 15 mm and the karyotype is normal, 90% of these will resolve. In contrast, if the diameter is more than 15 mm, then the chances of chromosomal defect is 10%. But the prognosis is usually poor in this group as they progress into obstructive uropathy leading to hydronephrosis and dysplastic kidney. Next, I move on to the skeletal system. In the skeletal system, we have to see the upper extremities, lower extremities, and spine. At this time, the fetus is very mobile and we can see it from all different angles. So looking at the skeletal system is relatively much easier in the first trimester. So in both upper and lower extremities, we have to demonstrate all 3 segments of the limbs. In upper extremities, we have to look at the arm, forearm, and the hands. In the legs and the lower extremities, we have to look at the thigh, leg, and feet. Also, we have to look at hands and feet to look for polydactyly. Now, this is from the previous case of trisomy 13. The baby had polydactyly. We can see there are 6 fingers. This is a post-axial polydactyly. This is a postnatal picture of the same fetus. So polydactyly can be an isolated finding or it can be associated finding. If it is an isolated finding, then there's 50% chances of the familial inheritance, or it can be associated with these syndromes like 13 and 18. And post-axial polydactyly, that is when the small finger, the 5th finger has the extra finger, is defined as post-axial. And when the thumb has an extra finger, that is called the pre-axial. Pre-axial is rare and the post-axial is more common. Now, I have discussed the indirect markers of the neural tube defect in the brain itself, but we have to look at the spine directly also. Since the fetus is small and more mobile, it's very easy to look at the spine in toto. So we have to look at the spine in which sagittal and coronal planes. We have to look that overlying skin is intact and look at the vertebral column from neck to the tailbone. If we are not able to demonstrate the clear-cut open neural tube defect in the first trimester, and we only see indirect signs, so we have to call the patient at 15 weeks. And in open neural tube defect, by 15 to 16, we'll be able to demonstrate the clear-cut open neural tube defect, and all the florid signs of intracranial abnormalities will be seen. Now I'll be presenting a short video. This is a 3 minutes video demonstrating that in 3 minutes we can pick up all the major abnormalities. This was the picture of the CRL. Now we move on to head and brain, choroid plexus, the third ventricle. This is the third ventricle, the bilateral choroid plex. We move slightly more down. We magnify the picture. This is the aqueduct, the cerebral peduncles, the orbits. It's an active baby. We now will go on to heart. First confirm the situs, left-sided stomach. I put in color to look at the various views of the heart. We see there's an equal amount of filling of both the right and the left side of the heart. We can see the LVOT or aorta coming out of the left ventricle. That's the LVOT. We move higher in the chest. We can demonstrate the 3 vessel trachea view or the tick sign. Now I'm trying to demonstrate no ARSA. So there is no ARSA in this case. This is right subclavian artery, just curving like an S. There is no ARSA in this case. So it's easier to demonstrate ARSA in first trimester. Now we move on to different other planes of the baby. So we see that the spine looks intact. This is the bladder. Now I'll put in color to demonstrate 3 vessel cord. That's a 3 vessel cord at the level of bladder. I magnify the view. Now I'm trying to look at the lower extremities. We can see all 3 segments of the lower extremity, thigh, leg, and foot. That's the other foot here. So magnification is very crucial. We should magnify the images. We can demonstrate both the feet. It's an active baby, all 3 segments, and the foot. We can see the toes clearly. Both the orbits can be seen. Intraocular lens could be seen. Now I'm demonstrating both the hands. We can clearly see all the 5 fingers of the hand. All 5 fingers nicely. This is the other hand. It's an active baby. So all 3 segments of both upper and lower limb needs to be demonstrated. And we take a 3D color picture. This makes parents happy. At the same time, we can document both the hands. Also, we can see a small ear there, and there's no cleft lip and palate. So this was a short video, 3 minutes video, in which we could pick up all the major abnormalities in the first trimester anomaly scan. My take-home message for today is the first trimester scan is very important from aneuploidy, not only from aneuploidy, preeclampsia and preterm screening, also for screening major structural abnormalities, giving early reassurance to mother. And in case of major abnormalities are there, there's an easy termination, and genetic counseling and procedure, if required, can be done. Thank you everyone for your kind attention.
Thank you so much, Dr. Sabitha, for such a quick synopsis of the value can never be overstated. Thank you for reminding every one of us that we have the importance of checklist, which we use for NT&B scans. The value of doing the scan in the same order and seeing every organ every single time, even if the position is not conducive for the scan. Here I can just add a few things that the picking up of spinal abnormality somehow is easier during NT&B scan than sometimes in level 2 scan because the bones are not yet so much developed. One more thing I can add here, there is a very good indirect marker which I use in most of my scan is the upliftment of the sacral curve. It gives us an easy, it's an easy marker and it is very, very valuable in a lot of scans with where sacral agenesis, milder form of sacral agenesis is there. So that has really helped me pick subtler signs of sacral agenesis, the subtle upliftment of sacrum in the true SAT scan. So thank you so much for the delightful images. And I also want to compliment the members of AOGD for the wonderful, wonderful work they've done, such meticulous planning, Dr. Seema. Really, really hats off to all of you. And thank you so much, Dr. Sabitha, for a wonderful presentation. Thank you.
Yeah. Vandana, would you like to give us some insights from your experience, Dr. Vandana?
Yeah, so definitely congratulations, Dr. Sabitha, for such a wonderful talk. Am I audible? Everybody?
Yes, Dr. Vandana, you're audible. Thank you very much.
Your camera is little, your face is not visible fully.
Okay, because of the mask?
No, not because of the mask. Yeah, now you stand up. Okay.
Better?
Yeah, now it's okay. Yeah.
Okay, so congratulations, Dr. Sabitha, for the wonderful talk. I think she has covered all aspects of it. I can only say that yes, increasingly the pyramid of care is shifting to the nuchal scan, and we are picking more and more anomalies in the first trimester, especially now with the advent of so many multiple pregnancies. We try that we should be able to pick up a structural malformation early in the pregnancy so that we can manage the pregnancy accordingly. And in fact, I was looking at a paper by Sinjalaki. I think the first paper published for the first trimester anomalies by Sinjalaki in 2013, as early as that, said that they are able to pick up a lot of stuff. And the same author has published saying that even in twin pregnancies, they are able to pick up a lot of anomalies in the first trimester. So I think for heart defects also, in our experience, other than a few valvular anomalies, we can pick up or venous anomalies, we are able to pick up most of the stuff in the first trimester. And as Dr. Sabitha has enumerated, the take-home message I want to give, there is no excuse for not picking up an acronia, holoprosencephaly, and limb body wall defects. I think omphalocele, those should definitely be picked up in the first trimester. I think none of us should be excused for acronia. The sensitivity of the first trimester scan should be close to 100% in all of our practices. And I think now we are hardly seeing any anencephalies now in the second trimester. Most have been picked up as acronias in the first trimester. So I think that should be the take-home message. The must-pick anomalies. I think the number one, acronia, holoprosencephaly, omphalocele, limb body wall defects, and maybe Sabitha can add something else to that, but these are must pickups.
Yeah. So thank you, Vandana. I would just like to add, because all these picked, those which can be 100% pickup is all these anomalies. And why this is important in Indian context, as you know, our MTP law has not yet allowed us till 24 weeks. It is still 20 weeks only. So if we do by 12 weeks, then repeat by 16, still we have more time to work out. So actually, this is the need of the hour for our country as well. So we have to move as soon as in the first trimester. So that we have enough time. So now with these, now we move on to the second session, which is again on the common congenital abnormalities only, but this is in the second trimester scan. And I would like to invite our chairpersons for this session. Shivam, I need the CV slides. So I would welcome Dr. Leena Sridhar. She is working as a senior consultant obstetrics and gynecology at Manipal Hospital, Dwarka, New Delhi. And she is an HOD of academics and research of this hospital. She is also the member of the ethics committee of the Manipal Hospital. She is an alumni of Maulana Azad Medical College, and she did her MD from Safdarjung Hospital. And she took voluntary retirement from the rank of colonel from Army, and now she is practicing obs and gynae in the private hospitals. She has received the Superheroes in White Coat Award on National Doctors Day on July 1, 2020, and received Women's Achiever Award on International Women's Day on 9th March 2019, and Dr. APJ Abdul Kalam's Appreciation Award, Delhi Gynecologist Forum on 1st January 2021. And she is currently Joint Secretary DGF Southwest, and she is also a Joint Secretary for DGF Dwarka and Executive Member of the Multidisciplinary Committee AOGD and Executive Member of the Reproductive Endocrinology Committee AOGD. Welcome, Dr. Leena. Next slide, please. And now I welcome Dr. Prakash Lal Chandani, who is a well-known figure in Dwarka, and he is a well-known figure for the IMA as well. He has done his MBBS for UCMS Delhi and MD Radio Diagnosis from Delhi University. He is a member of Indian Radiologist Imaging Association, member of Indian College of Radiology, Indian Medical Association and Delhi Medical Association, and member of Dwarka Sanghi. And he has various positions held, like Presidents of Delhi Chapter, Indian Radiologist Imaging and Association 2018-19, and State Coordinator Delhi Chapter PCPNDT. And he is also a member of Indian Radiological and Imaging Association. Welcome, Dr. Lal Chandani. Next, please. Now I welcome Dr. Preeti Tahaliani, who is a consultant Obs and Gynae at Venkateshwara Hospital. She has done her MBBS and MS from SMS Medical College, Jaipur, and senior residency in DDU Hospital, New Delhi. And she has been trained in minimal access surgery from AIMS. And she has been attached to in the past from Dr. Narendra Malhotra Hospital, Agra, and DDU Hospital, Delhi. Post PG work experience, 15 years, and she is a lifetime member of FOXY AOGD, and she has a special area of interest in infertility and laparoscopy. Next, please. Now I welcome Dr. Taruna Dua. She is currently a senior consultant working at Akash Hospital, Dwarka, and Gynae and Infertility Clinic, Janakpuri. And she is a lifetime member of FOXY, MNMS, and she is a treasurer of DGF Southwest. Welcome, ma'am. Now I request
Thank you.
Now I request our chairpersons to introduce our second speaker, Dr. Aditi, and she'll be speaking on common congenital.
Hello, everyone, and a very happy Ganesh Chaturthi to all of you. On this wonderful day, we are here to have deliberations on the common congenital anomalies in the second trimester scan. And I think this is a very important topic, especially when you want to send a message to us obstetricians. Thanks to the AOGD Fetal Medicine and Genetics Subcommittee for having me here as a chairperson. And I have the pleasure to introduce the speaker for this session, that is Dr. Aditi Shastri. Dr. Aditi is an MBBS from BJ Medical College, Pune, and has done her DNB also from Pune. She has a fellowship in fetal medicine from the Rainbow Hospital at Hyderabad, and she's a Fetal Medicine Foundation UK accredited doctor. She's presently the consultant Birthright Madhukar Rainbow Children's Hospital in New Delhi. Her area of interest are fetal interventions and therapy, with management aspects in the smooth functioning of the fetal medicine units. And also she believes in affordable, sustainable and quality care for all. So thank you very much, Dr. Aditi, and we look forward to hearing you speak on common congenital anomalies in the second trimester scan.
Thank you, ma'am, for that lovely introduction. May I start my presentation?
Yes. Share the screen. Full screen.
I think we need somebody to mute themselves. There's some background noise.
I think I'll start. Very good afternoon to everyone and a very happy Ganesh Chaturthi. This is coming from a person who's basically from Pune, so I'm really missing home today. Thank you, Dr. Seema, for giving me this opportunity to talk to everyone. So after that talk by Dr. Sabitha, I'm sure all of you all are thinking, what's left out in the second trimester scan? Huh? I mean, they can pick up almost everything. But what I would like to tell you all is that though that is the case with tertiary centers and good quality centers in places like Delhi, not necessarily the same story which is happening out there in the periphery. In fact, just to throw some numbers at you, Worldwide also, there are almost 3 lakh newborns who die within 28 days of life every year. And we say that only about 2 to 5% of pregnancies are affected with malformations. However, recent meta-analysis in India say that nearly 184 per 10,000 births. Those are the huge numbers of children born with anomalies, even in today's day and age. So a good anomaly scan has still got only about a 40 to 60% detection rate over and above the first trimester scan. And like the previous speakers said, that protocol. The more you stick to them, the better you will get at picking these up. And what better than ISWOG? So ISWOG has proposed these 20 planes and 2 sweeps. So we start with sweeping longitudinally from the head to the body for an initial orientation of the lie, of the situs, and then we go on to each of these planes progressively, and then in the end we do another transverse sweep from the sacrum, 1 vertebra up at a time. So ISWOG says that we should be able to exclude at least 50 abnormal appearances. Yes, 50 abnormal appearances in just this basic 20 plus 2 planes. So it's a very vast topic. I'd like to take you through a few anomalies in each of these planes. I'm sure there would be a few overlaps between what Dr. Sabitha has already told us, so please bear with me. I'll start with the spine. We go to the 3 standard planes, which is the axial, sagittal, and the coronal plane. And let's not forget imaging of the sacrum. We must definitely be able to pick up some of these. As you can see that there is a huge number of abnormalities that we can go through. So kyphoscoliosis, your diaphragmatic hernias, open neural tube defects, masses at the base like the sacrococcygeal teratomas and sacral agenesis. I would quickly like to talk to you about the open neural tube defect. So the incidence is about 1 in 1,000. The lumbosacral ones are the commonest, and they are associated with the Arnold-Chiari malformations, which has a prominent caudal displacement of the brainstem and obliteration of the cisterna magna. 95% of them are associated with the scalloping of the bones of the forehead, which is the lemon sign, and the cerebellum gets pushed to the back and gives a typical banana appearance with the concavity faced forwards. Ventricular enlargement is seen in nearly 70% of the cases. They are associated with trisomy 18 and single mutant genes, maternal diabetes, and consumption of anti-epileptic drugs in nearly 10% of the cases. Non-chromosomal syndrome risk is low, so at least a karyotyping can be offered. They have not a very good prognosis, needless to say. The 5-year mortality rate is nearly 35%, with almost 25% being stillborn. In the survivors, the lower limb paralysis, double incontinence, and a multitude of problems would come up, especially with the kidneys. However, the interesting thing is that these children, even if they have hydrocephalus, may still have normal intelligence. There is also a significant recurrence rate, and so we are all familiar with folic acid supplementation to prevent the recurrence. A quick note about closed spinal dystrophism. These are difficult to pick up even in the second trimester anomaly scans because the cranial signs would be absent most of the times. This is when we need to look for cord tethering. So we look for the end of the conus in our sagittal view with a slight tilt, and then we would be able to literally count where exactly the conus ends. In a normal level 2 scan, the conus should end somewhere around L2, L3 vertebra. Anything lower than this should prompt us to investigate further. Now I'm moving on to the head and the brain. Again, our 3 standard planes of the transventricular, transthalamic, and the transcerebellar planes. So with these, we have a myriad of problems which we should be able to pick up. The lobar and lobar holosuprasencephalies, the encephalocele, though I agree that these are definitely going down. Cystic hygromas, posterior fossa cysts, and then of course the ventriculomegalies. Now a little bit about ventriculomegaly. These are seen in nearly 1 in 100 cases at 20 weeks. We classify it as mild, moderate, and severe, depending upon the size. They are associated with the major trisomies in 10% of the cases. What we need to remember is that if the ventriculomegaly is severe, the chance of it being associated with a trisomy is going to be relatively less. It's the mild ventriculomegalies which have a 4-fold increase in trisomy 21. Of course, there has always been an association with the other genetic syndromes, and anything that you see in the brain, we must go ahead and do a detailed neurosonography, which is obviously better done after 24 weeks. Offer an invasive testing, including a microarray. Look for signs of fetal infection, so the torch test, as well as think of signs of hemorrhage in the brain, which may be causing the ventriculomegaly. MRI can be offered, but it is more sensitive after 32 weeks. This is for looking for abnormalities of neuronal migration. Now, the prognosis. So most of the times, the minute we tell a patient something with the fetal brain, you are going to prompt them to think about termination. So another thing we could tell them is that in the mild ventriculomegaly cases, which is about 10 to 12 mm of dilatation, the neurodevelopmental delay is only seen in about 10% of the cases, which is not much higher than what can be seen in a general population. Of course, in the severe cases, the mental handicap is nearly about 50%. And once again, we must keep recurrence in mind when we work them up the next time. Now I have a short video of, excuse me. Just give me 1 minute, please. Okay, so there we are seeing a video of an absent corpus callosum. Not very easy to pick up every time, but definitely you can pick it up if you have your antennas up. So we should be seeing a teardrop ventricle, where the posterior part of the lateral ventricle looks like a teardrop. And if you look carefully at this cavum septum pellucidum, it's absent, and you see 3 lines in its place. So unfortunately, it has a very, very wide spectrum. It could be completely absent, partially absent, and a sagittal view would give us a better information as far as how much of it is formed, and the abnormal course of the pericallosal artery will also help us. The usual length is about 18 to 20 millimeters at 20 weeks gestation. Once again, the associated abnormalities with trisomy 8, 13, and 18, and various genetic syndromes. So one must offer invasive testing and a detailed neurosonogram. Why I wanted to bring out the absent corpus callosum is that here the neurodevelopmental delay is varied, and the counseling becomes difficult. And however, the neurodevelopment delay can go up to 30%. And if it is associated with other conditions, then the prognosis can be quite poor. Next, we have the thorax plates. So this work says that its basic scans is good enough to look for the 4-chamber view, the RVOT and the LVOT and the crossing over, as well as a 3-vessel trachea view. Even here, you should be able to pick out a bunch of abnormalities with the heart, basically the large VSDs, as you can see, the overriding of the aortas, the thoracic abnormalities, the CPAMs. In the 3-vessel view, the TGAs can be picked up, especially if you're not able to see all the 3 vessels. Univentricular hearts, axis deviations, situs abnormalities, as well as arch abnormalities can also be picked up. So I would like to tell you all a little bit about the congenital can you see my slides?
Yes, ma'am. Just make it full screen.
Just give me a minute.
Yeah.
All right. So coming back to the congenital pulmonary adenoma malformation. So I've put a video here where you can see a baby. It just hits you. I mean, you can actually see something much brighter in the chest if it's associated with a large cyst, which is the macrocystic kinds, where the cysts are more than 2 centimeters. Then you start thinking, is this the stomach? But no, as you can see in the video, the stomach is very nicely placed at the bottom below the diaphragm in its correct place. So we have the microcystic, macrocystic, and the mixed variants. They're usually unilateral, and hydrops is seen in less than 10% of the cases. These can present with polyhydramnios a little bit later, after 26 weeks. Chromosomal abnormalities are usually not increased in these cases. So here again, we need not think of invasive testing as the first thought. However, if it is associated with other conditions, then you would definitely think of invasive testing. So the new thing in the CPAM, relatively newer, is the CVR, the CPAM volume ratio. So here what we do is we take a volume of the malformation, and then we go ahead and we multiply it with a correction factor of 0.52 and divide it by the head circumference. Now, if the CVR is less than 1.6, the risk of hydrops is relatively lower, and this is obviously in the absence of a dominant cyst. And if the CVR is more than 1.6 and there is a dominant cyst, then these patients need a little more frequent follow-up to look for hydrops and obviously the evolution. So most of the microcystic kinds of CPAM, they would resolve. They say that this is not a true resolution in most of the cases. It's just that the CPAM is not very visual, very well visualized on the scan. However, these children do well. So what I would like to emphasize on is that a CPAM would look very scary on the scan to a common person. However, if it is the microcystic kind, then these children actually do well. And betnesol, there are a few papers which say that giving betnesol improves the outcome. And with good NICU and pediatric care, more than 90% of these do well. Now coming to the abdomen and the pelvis, again, all the standard views that we see, we look at the cord, we look at the placement of the stomach and the spleen, the kidneys and the cord. So here we are with some of the major things that we should be able to see. So the hydronephrosis, the multicystic dysplastic kidneys, which again will just be obvious. Like we heard Dr. Sabitha say, not so common in the second trimester because these should be picked up. It's been a while since we've seen any of these in the second trimester. However, just to complete the list, the omphalocele and the gastroschisis. Then we can at times look for features of duodenal atresia, ascites, of course, and then the lower urinary tract obstructions. Again, most of the times these would be picked up in the first trimester. By the time we come to the second trimester, we would have very badly damaged kidneys and the single umbilical artery. So a quick word about the hydronephrosis. Again, seen in 1 in 500 births. In 2014, there was a consensus with various bodies which came together and put forward the UTD classification, that is the urinary tract dilatation classification. This was done because there didn't seem to be any correlation between exactly what the dilatation was, what the obstetrician needed to do, and what the pediatrician needed, how the pediatrician needed to follow up later, whether they would need surgery or not, how to counsel these patients. So they put up the UTD-A, A standing for antenatal, and then of course there would be the UTD-P, which is the postnatal. So the UTD-A1 is when the anteroposterior diameter of the pelvis is between 4 and 7 millimeters, between 16 and 27 weeks. Beyond 28 weeks, this increases to more than 7 and less than 10 millimeters. And this can be or without central callosial dilatation. With the UTD A2 to 3, the dilatation is more than 7 millimeters in the second trimester and more than 10 millimeters in the third trimester beyond 28 weeks. Peripheral callosial dilatation, abnormal thickness in the parenchyma, abnormal ureters and bladder, and unexplained oligohydramnios would all go into UTD A2 to 3, irrespective of the APPD. So these, again, the isolated conditions, the chromosomal defects, the chances are low that this would be associated with the chromosomal defect. I know you all are thinking that, oh, but it is one of the markers for trisomy 21, but it is not as strong a marker as the others are. And however, yes, if it is associated with abnormalities in the contralateral kidney, abnormalities in the placement or renal agenesis in the contralateral kidney, then definitely we should be offering invasive testing. So we really need to evaluate the contralateral kidney very well. And karyotyping can be offered only if other markers are present. So I've put in 2 pictures of UTD A1 and A2 to 3 for your comparison. And as far as the prognosis goes, the UTD A1, that means these are the mild hydronephrosis is what we used to call before. These usually remain stable or resolve even antenatally. If not antenatally, then definitely in the neonatal period. Don't require very stringent follow-up, just probably one check ultrasound after delivery. 20% of these, that is most of these, are associated with uretropelvic junction obstructions and refluxes. And these may need follow-up and possibly surgery also. When it is moderate to severe, these can be progressive. More than 50% of these need surgery in the first 2 years of life. So here is where the counseling of the patient would change. Next, we come up to the limb planes. And some of the abnormalities, we should be able to pick up fixed flexion deformities. So look for the movements, the opening and the closing of the limbs properly. And of course, some forms of skeletal dysplasia can be picked up, as well as the club feet. So coming to the club foot, the CTEV, again, a very common abnormality to find in the second trimester. And I think we have a video here which shows bilateral clubbing of the feet, where the sole of the foot is not perpendicular to the lower leg bone. So you're seeing both the bones as well as the sole of the foot in the same plane. It is more than 50% are isolated. However, it has a strong association with trisomy 18 and 13. It can happen if there is prolonged oligohydramnios, brain abnormalities, spina bifida, and neuromuscular disorders. More than 250, yes, 250 genetic syndromes, which include one clubfoot as their component. So if it is not an isolated condition, definitely offer testing. And if it is isolated, the prognosis is good. More than 90% of the children do well with manipulation and serial application of casts. Surgery may be needed in 10%, and a very few of them need more than one surgery. So again, here I would like to bring out that if it has, don't forget your genetic causes also, because people tend to think that clubfoot would just be fixed with surgeries and casts. There is a recurrence rate, so we must keep that in mind while scanning these patients the next pregnancy. Coming to the face, we look for the profile, we look for the orbits, and we then look at the coronal view and look at the lips and the nostrils. The standard view for the palate has not been included in the ISWOG protocol. However, I think it would be quite easy to obtain once you are trained. So here are some abnormalities which we should be able to pick up. So we have the micrognathia. We look at the profile. We could pick up frontal bossings and the flat faces, binders, anophthalmia or cataracts in the lenses, which are indicative of looking for fetal infection. And then, of course, the bilateral cleft lip and palate, bilateral or unilateral for that matter. So the cleft lip and palate is seen in more than 1 in 700 births. Male fetuses are more affected, and in about 50% of the cases, it is both the lip and palate which is involved. When it is only the palate which is involved, that would be difficult to pick up. And it is unilateral most of the times and bilateral in 25% of the cases. Again, a video showing you all the bilateral cleft in the palate and the lip in the coronal section. And so we need to look for other abnormalities, again, the association with trisomy 13 and 18, which is not much, usually only in 1 to 2% of the cases. Unilateral cleft is not associated with chromosomal abnormalities most of the times. However, more than 400 syndromes, and these in more than 30% of the cases are associated with cleft lip and palate. So with a multidisciplinary approach, usually when it's isolated, there is a good and normal survival, and the surgical repair is a beautiful surgical repair is available nowadays, and it can be done as early as 3 months of age. However, we must keep in mind that they can face some long-term issues like the dental issues and hearing issues, as well as, of course, the psychosocial problems. Once again, recurrence rates are significant, so we must keep those in mind. So to conclude, I would again like to emphasize that stick to protocols. We use the Viewpoint software here, so that helps us to keep a checklist. Make a checklist of your own, just go through each and every plane, and then, like they say, you should be able to exclude, even if not diagnose, but at least exclude, at least know that there can be something which is not so right. Next is that once you find one abnormality, make sure you look for the others, look really hard. Don't be afraid or don't hesitate to offer invasive testing. It's always good to offer a little bit of, to offer invasive testing, because that gives reassurance to the parents at a different level. Communication is really important. Otherwise, usually you may be telling them that something is not having a very good prognosis, but they are understanding that there is a surgery possible. So try to understand the patient's mindset and communicate to them well. And of course, the eyes only see what the mind knows. So keep updating yourself so that we could, offer more and more and more to all these patients. Thank you so much.
Yeah, Dr. Prakash.
Yeah, am I audible?
Yes, yes.
At the outset, I must compliment the team AOGD and organizing team for organizing this superbly executed workshop. I must appreciate the efforts of Dr. Aditi Shastri for covering this vast topic so comprehensively in the given limited time. Though this topic requires an entire day of deliberations, but 30 minutes, I think she did justice to the
20 minutes. Yes.
As the saying goes, we are as good as our last scan. So adequate time must be spent on the detailed anomaly scan for maximum yield in this particular setting. Because we just can't afford to lose and miss the anomalies in the present scenario. At the end of the scan, we must be able to declare with the confidence whether the baby is structurally normal, or is there any firm deformities there or not, or third, any suspicion of anomalies there or not, so that it can warrant the further investigations or any serial scans to be done. So this is what the ultimate aim of the detailed anomaly scan is. Though I must admit, the paradigm is being shifted to the first trimester's scanning because of the MTP restrictions. But still, in the given scenario, the second trimester scan is still considered to be the best possible scan or best possible time for the scanning throughout India, not in the major urban centers, but periphery also, because this is the time the skill quotient is still the best in this particular frame of gestation. Last but not the least, but I would like a very small point. I urge everyone not to use this terminology level 2 scanning anymore. Level 2 is a misnomer. We must use the detailed anomaly scan, the terminology. Why I'm saying so? Because this is being used very frequently in the referral slips also. Now, just few days back, a radiologist, where the raid has taken place by the inspection team, he has been denied bail for this particular reason, because the referral slip said level 2 scan. At 25 weeks, he refused the scan and he did the fetal well-being scan. See, this was the reason for denying the bail. So you must understand, level 2, the judicial records don't recognize level 2 as an indication of any ultrasound, because it is not included in 23 lists in the Form F. So my request to all the participants not to use the level 2 word in the referral slips or in their reports also. Thank you so much.
Yeah, that's a very practical suggestion. Dr. Vanna, we are waiting for your insights. Yeah.
So I'll just use the keywords here. Am I audible?
Yes, 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 very much.
Again, checklist, adequate time, counseling that everything can't be picked up, especially the CNS anomalies. Like every time I get a call when the baby is born saying, "Shayad ye lag raha hai, wo lag raha hai," you have to know what is the sensitivity detection rate for different anomalies. And for example, if a baby has esophageal atresia at birth, what could be the sensitivity of picking up esophageal atresia at 20 weeks? And if you have missed it, how confidently you can put up your case to the family or to the obstetrician who has referred the patient to you. So you should know which ones are picked at 20 weeks, which at 24 weeks, which will be picked up later. That checklist and those figures should be clear in our minds. And never hesitate to take a second opinion if you suspect something. Documentation is the key. Everything you see, documentation is important. How you give your pictures to the patient as well as save your images. And not everything which is large and stark and abnormal looking is, for example, a small ventricle, a small omphalocele, or a small pelvic ectasis, or a small median cleft. These may be associated with chromosomal defects, but a very large CCAP or a very large looking, horrendous looking gastroschisis, these may have almost very good prognosis. So make sure that you sit with the family when you have diagnosed something and tell them the possible options, and don't just terminate pregnancies as a knee-jerk reactions before talking to the families, which fetuses, because we are not there to make that choice for them. We are there to tell them the options in terms of what is salvageable, what is not, what are the options, and let them make that choice. And I had a question for the esteemed faculty here, that if we change our PP Act to 24 weeks, the anomaly scan, would it still be at 20 weeks, or some of us are thinking of doing 2 anomaly scans, or would we be shifting our anomaly scans at 22 weeks, or that's just a food for thought for the future? Because I've been toying with that idea, especially with the BMIs going sky high and everybody being above 100 kilos in our clinics. Should we be looking at doing another anomaly close to 24 weeks, so that we can give them better pickup rates for certain things which we'll miss at 18-20? So that's just food for future thought. Thank you so much.
So before, I know we are a little bit behind time, Dr.
Yeah. So now
Dr.
with this,
Seema.
so thank you, chairpersons and speaker, for this session. And with this, we move on to the third session, which is the congenital cardiac abnormalities, what you should tell the parents. Shivam, please share the screen. Yeah. So the chairpersons of this session are, I would welcome Dr. Deepti K. Yadav, and she has MBBS MS, Ops Gynae, and she has been trained in minimal invasive gynecology from AIMS New Delhi, India, and she has a certificate in advanced infertility management, June 2015, New Delhi. She has attended workshop in color Doppler ultrasound, August 2015, and she has done a certificate course for Foxy-Gestosis. And her present appointment is, she is working as a senior consultant and unit head obstetrics and gynecology at Venkateshwara Hospital, Dwarka, New Delhi. Welcome, ma'am. So next, please. And now I have a pleasure to invite Dr. Alok Vashni, and he is a well-known figure, and he has done MBBS, MD, and DNB radiology. He is a consultant radiologist and director at Central Diagnostic Dwarka, New Delhi. He has done his MBBS from UCMS, MD from Safdarjung Hospital, New Delhi, and he is a member of IRIA, Society of Fetal Medicine. And he has been in ultrasound practice for 20 years and presented papers and delivered lectures at various national and regional conferences organized by SFM IRIA and Indian College of Radiology. And he has been awarded first prize for the poster Cross Pulmonary Arteries at the SMF International Virtual Conference in 2020. Welcome, Dr. Alok. Now I request chairpersons to introduce our speaker, Dr. Smitha.
Seems Dr. Deepti is not there. Is she here? Okay, it gives me great pleasure to invite Dr. Smith Mishra for the next talk. She is a pediatric cardiologist. She is the head of department of pediatric cardiology at Manipal Hospital in Sector 6, Dwarka. She has been an active member of the Indian Academy of Pediatrics. She has served as various positions in IAP, and she has helped formulate various consensuses on timing of intervention and drugs to be used in pediatric cardiology. And she has won the Best Doctor Award by IMA in 2013. And she conceptualized the Spandan program, which was adopted as Atal Bihari Hriday Upchar Yojana in Madhya Pradesh, I think. And what this CV doesn't reflect is that she's a brilliant poet and a sensitive writer, and she has a great way with words, and she's the best person to tell the parents what to expect when the baby has a congenital heart disease. So I invite Dr. Smith Mishra for the next talk.
Can I share my screen? Thank you very much, Dr. Alok. And I am really thankful. Seema, you are doing great. So, share screen here.
Me? Yes, we can see.
So, thank you so much for this opportunity. Happy Ganesh Chaturthi to everyone. And with the name of God and Bhagwan Ganesh, I start this particular session on congenital cardiac anomaly. What should you tell to parents? Am I audible? My voice is little bad because I have a viral infection. Am I audible?
Yes, yes, we can hear you.
So and now things are very different in last 50, 70, 80 years. And fetal rights are emerging issues, as now fetus may have advocates. The prenatal counseling has a human aspect, but also medical legal bearing. So we need to be very careful about our words and our sentiments which are being expressed. So whenever we do fetal echocardiogram, we may get a normal heart or an abnormal heart. This abnormal heart has a future of either termination, or it may have a demise on its own, or this baby may born alive, and then we have to assess this baby, and then we have to decide on the management plan. So now, what are the premises of prenatal counseling? One is the immediate issue, better planning we want to do. Delivery should be done at a tertiary care center or nearer to tertiary care center. we have to look at the financial aspect, the fetal well-being, and what is the scope of intrauterine treatment in particular center, and is a reason to terminate a pregnancy, or there is a possibility of a spontaneous abortion. What will be the overall outcome? Intervention, if they are required, when and what kind of. So we need to know the what could be a procedure, what could be a risk of procedure and overall outcome. But things won't stop there, because you have to answer, बेटा खेलेगा कि नहीं, कितने दिन रहेगा, शादी हो सकेगी कि नहीं, बच्ची है तो childbirth. So these are the things which these questions will keep on hovering the family, and we have to answer them very convincingly. The risk for the coronary artery disease in long run, myocardial dysfunction, genetic aspect of the disease, endocarditis prophylaxis, possibility to go for use of any other drug for a long-term basis, and then possibility to go for cardiac transplant or a brace therapy. The timing of antenatal counseling is also important. Most of the time, pediatric cardiologists, they actually enter into the fray around the around the time of anomaly scan. There may be a first trimester diagnosis of the congenital heart disease, and it may be very convincing also, and at that particular moment a combined decision can be taken. But most of the time, like we had presented a paper also with Dr. Neha, so in that case we did first trimester counseling and followed by these anomaly scan, and then declaring the result and giving final word to the family. So there might be a late detection of fetal heart disease, and that will have its own issues. So prenatal counseling is a complex task, and that requires skill to perform and interpret fetal echocardiograms well, and understanding of fetal and postnatal cardiovascular physiology, knowledge of therapeutic and surgical options, and long-term outcomes, including the what would be quality of life. So prenatal counseling is a tool to provide a right information about the fetal condition without any effort to impose upon the parental decisions. It must be delivered in a right tone and words in the proper surroundings, usually involving all the decision makers of the family and with the consent of the parents. It is better to give 2 rounds so that parents may have a time to assimilate the information. The other thing is one should be very careful about not using any negative word about the previous misdiagnosis by any other center, particularly when you are going to get a late diagnosis of fetal heart disease. Suboptimal outcome must not be exaggerated. Neither must be oversimplified. At the same time, to be mindful of its impact on the patient's emotional and psychological coping. Patient can be allowed to consult the appropriate literature or seek second opinion if they want to. Additional meetings with the interventional cardiologist, cardiac surgeon, neonatologist, lactation consultant. You must know that if baby is going for a surgery even and getting after that might be improving also, but still there will be a period where the lactation will not be possible for mother. So nurse also, these are the things which meetings should happen beforehand. So interactive meeting between the fetal medicine, obstetric consultant and geneticist. This is very important. The prenatal detection of a cardiac anomaly must be first analyzed and understood amongst the all of above, so that you should not be talking on two vices. Decision to terminate pregnancy is a real option, but as we know, there may be an underlying inheritable propensity. All efforts must be made to convince the family for appropriate procedures. If termination has been opted for further analysis to find an accurate diagnosis, additional anomaly if it is there, and the genetic aspect of this. We must know this is not about the money. This is not about the mental tension, but this is all about the taking care of whole family. A genetic aspect of disease is very important, and you can actually advise on the other family member when they have a pregnancy. So this is very, very important part. Then advice for the future pregnancy is very important part of whole counseling process. So appropriate screening of further pregnancy for the same mother and other family members. Advice on the metabolic syndromes, diabetes mellitus, autoimmune disorder. So there are some therapeutics is available, or maybe certain factors can be avoided. So those things should be counseled. The avoidance of cardiotoxic drug infection, adopting the cardioprotective diet and drugs vaccine. These are the things which we must know and we must be able to answer. Because the parental common query is, what was the cause of the heart disease? What was the etiology? Why it happened with us only? So one part is inheritance, genetics. There may be familiar form of a disease, autosomal recessive or dominant trend, even sex-linked disease may be there, inheritable as the part of chromosomal disorder, particularly if extra cardiac anomaly has been detected. These are certain congenital syndromes which particularly should be suspected once you get a extra cardiac finding along with the cardiac anomaly. So the like cleft palate, or maybe polydactyly, or maybe cervical cystic hygroma, increased anti thickness, macroglossia, IOGRs, they all will tell about many syndrome like DJARS, like Alzheimer's, Turner's, Noonan. I'm not going to narrate the particular features of particular genetic syndromes, but these are the syndromes. Then there may be isolated mutation linkage analysis, like robust sequencing technology developed in recent years. They say that about 10% of serious heart disease may be because of these mutations. And there are a lot of other number of mutations are identified, and one should always look for them. Then most important part is epigenetic regulation of cardio-specific gene, DNA methylation, and that actually establishes a role of nutrition, infection, radiation, and environmental factor, and that also establishes factor of epigenetic diet. So this is epigenetic diet, where you use calculated proteins, amino acid, micronutrients. So this is a very important part of counseling. The fetus removal law. Now coming to fetus removal law in India, we know the abortion law in any nation depend on one essential inquiry: when does life starts? So the Medical Termination of Pregnancy Act in 1971, initially, these were the 4 legs of this medical termination indication, and less than 12 weeks, only one specialist was required, and 12 to 20 weeks, 2 specialists were required. And later, the mother's life in danger, then only it make a case for a termination. Otherwise, fetal abnormality was not taken into consideration. So in recent 2020 bill, it has been there are many modifications. Still, the age of abortion for the fetal cause about 20 weeks is not there. And we must know what are the federal bodies according to this amendment bill, and what are the legitimately approved age for the fetal removal. So these are the things we are looking forward to. So congenital heart disease, a heart disease presenting since fetal life, is the congenital heart disease, and mostly the 60% of these diseases are acyanotic. The classification of congenital heart disease, we know it may be a acyanotic heart disease, which are a simpler defect, and which may be even minor CSD, may be considered as a minor CSD, and the cyanotic heart disease, we are more or less composite disorder. So the acyanotic heart disease are shunt lesion, obstructive lesion, and the cyanotic may be TOF-like, TJ-like admixture lesion, and these CSD can also be taken as hemodynamically insignificant or significant. And this is my paper, and in this paper we have divided all the congenital heart diseases in the group A, B, C, and the group A, they are basically milder diseases. B and C may be moderate to severe. And whenever we are counseling, we have to counsel about the compatibility of a heart disease in fetal life, intrauterine intervention, or termination, longevity, intervention, a number of intervention required, what will be marriage, childbirth, quality of life, genetic counseling, kind of thing. The diseases which are not compatible are usually PFO duct obstruction, obstructive valvular heart disease, and of course the severe valvular regurgitation, and the diseases which cause ventricular dysfunction. They may not be, and there may be an indication for the termination of pregnancy and take neonate out. So this is my case one, 26-year-old pregnant lady with the fetal VSD. So what about the fetal VSD? Because the muscular VSD are commonest finding, and we get so many. So now, so we must know the VSD are perimembranous doubly committed muscular AV canal. To begin with, muscular VSDs are more, but at the end, at the birth, you will get the incidence of perimembranous more, because perimembranous VSD has 25% chance of spontaneous closure, while muscular more than 80%. So intervention will depend upon the hemodynamic effect. Any VSD less than 5 millimeter with no other abnormality may not need intervention. So there are studies which show that there is a spontaneous closure of VSD is quite high, and perimembranous type of defect, if it is less than 2 millimeter, and maternal age less than 35 years, then few of the studies, they identify it as a good prognostic factor for the spontaneous closure of VSD. Another study suggests that if baby is born, their family may call for the termination, but if otherwise termination is not required for VSD, around 7.3% only these patients may need a surgical intervention. A spontaneous closure, if you get a VSD at birth, is around 50%. So isolated VSD may be associated with other congenital syndrome, but if it is isolated, then probably we need not to bother more. Edith et al, they said that if it is an isolated VSD, probably you will have if you do a CMA, chromosomal microarray analysis, you will have similar kind of incident as it is in the normal population. So counseling will be usually termination of pregnancy is avoided, size of VSD should not be decisive, and open-ended prognosis must be given. VSD intervention are usually done between 3 to 6 months. Earlier, if it is required, low birth weight, prematurity, comorbidities may alter the Dr. Seema, Dr. Alok, should I finish over here? I have around 3-4 minutes more.
Yeah, you can continue.
Hello?
Please continue, ma'am.
You can continue.
Oh, okay. VSD interventions are used. So comorbidities may be a problem for a VSD prognosis. Chances of recurrence are not defined well as yet now. The inlet VSD, doubly committed VSD, may have higher chance of underlying genetic disorder. Isolated repaired VSD have very, very good prognosis lifelong. The case 2 is the 26-year-old primary isolated pulmonary stenosis in a primary mother, no family history of congenital anomaly. Incidentally, the patient was sent to me for the fetal echo, and I detected this. You can see this is the RV, which is dysfunctional. So any dysfunctional or dilated cardiac chamber gives a bad prognosis, and these are the cases where congestive heart failure may settle in, and we have to have a close observation and probably terminate a pregnancy. So valvular pulmonary stenosis isolated is an obstructive lesion, less difficult due to decompression of RA through PFO, so a baby can survive the fetal life. Outcome will depend upon the right ventricular function, dysfunction, dilatation. Intrauterine intervention may be required if there is a hypoplasia settling in for the right ventricle. Termination of pregnancy and neonatal intervention may be required, as I said, particularly in this case, which I showed you. And in severe cases, a case may be duct dependent. You may need to use the prostaglandin. So in pulmonary stenosis in isolate, I don't want to talk about this because I have a, there is definitely syndromal association, Noonan, Algile, Leopard, and linkage studies have shown association with hemophilia, non-compaction, HOCM. So the isolated significant PS, we have to do ballooning, and complications are quite less, success rate more than 90%, mostly one-time intervention. Long-term RV dilatation and dysfunction may settle in. And then coming to 30-year-old mother with the 2 antenatal reports of death. So a good size 2 ventricle we could see. Over here, this is LV, and this LV is not small, but we can see the LVOT, the thickening of the valve. So here the gradient was only 12 millimeter. It was a valvular pulmonary stenosis, but sometimes valvular pulmonary stenosis may go for a left ventricular hypoplasia, because this is known that HLHS may have a genetic predisposition, but it's also a hemodynamic disease. So bicuspid aortic valve may culminate into aortic stenosis or HLHS like complex. So bicuspid aortic valve very common in the general population. About 2% of all bicuspid aortic valve population may land into stenosis, regurgitation, or in a combined lesion. The severe fetal AS may need intrauterine intervention with success rate of 50 to 60%. The ballooning is effective for the non-complicated AS at birth and subsequently. But unlike valvular PS, there are chances of having subsequent intervention, surgery, Ross procedure, and all those things we have to explain to family. And if LV is not growing, not able to sustain the cardiac output, then it has to be a single ventricular repair, and patient may go for a Fontan kind of repair and subsequently heart transplant. So these are some genetic aspect, and we know Turner syndrome, Jacobson syndrome, and certain kind of genes, they may predispose for the aortic stenosis. And the calcification of valve also is being governed by certain SNP lipoprotein A for the lipoprotein A LPA locus. The HLHS is described as being a complex trait. A term commonly used to describe genetics in HLHS are genetically heterogeneous, variable expression, and the reduced penetrance. My case 4 is a transposition of great artery in a mother who initially had a TGA-VSD baby, and unfortunately she again landed up in another this TGA. So you can see this parallel great vessel. So this was another TGA. This TGA second pregnancy also TGA, and family opted for the abortion. But this is one of the common cyanotic heart disease. Early intervention is required for the TGA. First baby expired because early intervention could not be done. The parents were very, very poor. They were laborer. No syndrome, but genetic mutations are identified. Now it has been leaped into lateral T syndrome and group of situs disorder. And there are certain genes also identified. Then what should we counsel for DTGA? So termination of pregnancy remains one of the options before 20 weeks of gestation. Overall outcome depends on the anatomy, the timing of surgery. Timing of surgery in 2 weeks, and if one goes for the arterial switch operation in neonatal period, the mortality is less than 10%. Reoperation 2 to 3%. Good quality of life. Coronary issues must be watched for in long run. Then next case is a 36-year-old mother with the history of 1 abortion. Here the fetal ultrasound from outside recognized the VSD. We did the echo and we could see this overriding of aorta, VSD, and the smaller pulmonary artery. So this was a TOF and classical TOF. So in tetralogy of fellow, is one of the complex commonest CCSD. Chromosomal anomalies are identified, and D-Jaws syndrome, Down syndrome, they are the associated genetic disorder. And counseling termination of pregnancy remains a option below 20 weeks. Timing of surgery for a classical TAF is after 5 to 6 months. Reoperation in 20% cases at adolescent age group, because RV dilatation is there and a valve replacement may be required at the pulmonary position. Poor chance of survival if there is syndrome, underlying genetic issues, and isolated repair. So these are the thing. And then coming to conclusion slide, the ANC needs to be done after getting precise information about the nature of diseases. It must be honest and realistic. Decision making must be left on family, and chamber size is very important denominator about the mode of intervention and outcome. I would like to tell you a small poem by me on the TGA. So, oh my darling baby in the womb, let's celebrate a good news delivered with my report of ultrasound. Honey, you are growing happy and safe and set to come to world after all 9 months of it. So TGA, you need not to terminate pregnancy early, but there is a twist in tail. As doctor says, you will be a blue baby with transposed arteries of heart who forgot to reach their destined place. However, doctor knows the trick to switch it over forever within 2 weeks of your age. So, darling, we need not to worry. We will be patient, won't be hurry. These are only few days, as we have many long years together to catch up this delay. You may have to stay in ICU for 1 week or 2. It's pain for you, my love, and same for me too. Oh, my little baby, in the womb, we have a good news that though you have a war ahead, but you will surely win. So this is all about the antenatal counseling. Be hopeful. We don't be over optimistic, but you be optimistic, be hopeful, so that mother has a reason to smile over for pregnancy and for delivery of a baby. Thank you very much.
Dr. Alok.
Yeah. Thank you, Dr. Smitha, for this wonderful presentation, which outlines the challenges in what to tell the parents. As you said, the gist of the matter is our job doesn't end at the diagnosis. So we have to help the parents understand the anomaly. We have to prognosticate, present them with facts and figures, so that they can, arrive at a decision which is consistent with their beliefs. And we should not be imposing our own beliefs on the parents. So I've had patients who we have diagnosed HLHS, but they have opted to continue the pregnancy because their belief was such. Then, and I would also like to add that in complicated situations like these, there has to be someone who is batting for the fetus, someone who has to be the voice of the unborn, and who may survive, may lead a good productive life if it is allowed to survive. Sometimes the anomalies is just very little and it is correctable, but the parents are very scared to continue the pregnancy, so we have to counsel them very well. And the prognostication of any abnormality, it requires a multidisciplinary approach, and we should not shy away from referring the patient to a higher center or more learned colleagues. And this will help avoid future litigations as well. Thank you so much. Thank you, Dr. Smitha, for a wonderful presentation.
Thank you, Dr. Alok.
Yeah. So, Dr. Vandana.
I'm here. I think I agree with Dr. Varshney that this is a complicated situation, not just for the primary caregiver who would have seen the anomaly, but also for the parents. So a multidisciplinary approach where not just the ultrasonologist who's seen the anomaly, a fetal medicine specialist, a pediatric cardiologist, a geneticist, all of these, the obstetrician, all of these people will help the family in understanding the disease and taking the correct decision. So I think that is it.
Yeah. So thank you, speakers, chairpersons, and Vandana. With this, we move on to the next session, which is the management of multiple pregnancies with discordant anomalies. I introduce the chairpersons first, and I have a pleasure to introduce Dr. Geetanjali, who is a fetal medicine specialist working at Manipal Hospital, Dwarka. She has done her fellowship in fetal medicine from Mediscan, Chennai. She has done fellowship in clinical genetics from SGPGI, Lucknow, and former consultant fetal medicine at Fernandez Hospital, Hyderabad. Welcome, Dr. Gitanjali. Next. Now I welcome Dr. Yashika Gudesar, and she is currently head of department at Manipal Hospital, Dwarka in obstetrics and gynecology. And she is an executive member. She is a joint secretary with DGF Southwest, and her major achievements are specialized in painless surgery, laparoscopy, ultrasound, and medical legal systems and infertility. And she has awards for Dwarka Doctors Forum Award. And she worked previously in St. Stephen's Hospital, and her special interests are adolescent care, PCOD, painless labor, laparoscopies, postmenopausal care, gynae cosmetology, and high-risk obstetrics. Welcome, Dr. Yashika. Next. So welcome, Dr. Neeru Kiran, and she has done her MBBS and MD from MGIMS, Varda, and she is a consultant gynecologist practicing in Dwarka since 1990. She is an ex-lecturer at MGIMS Sevagram, ex-director Artemis Hospital Sector 20 Dwarka, past president IMA Dwarka 2015-16, chairperson Gynae Forum Dwarka 2011-14, and current also the chairperson. She is a member of Infertility Subcommittee AOGD, member of Multidisciplinary Subcommittee AOGD, and member of Reproductive Endocrinology Subcommittee AOGD, member of BCAP-SC AOGD, and she has lots of awards and medals like Dr. B. Sabni's Silver Medal Award, Medal for Standing Second in Final MBBS, Medal for Standing Second in Obs and Gynae in University Examination, and first Swasth Ratna Award for Exemplary Service, IMA Dwarka, and President's Scroll of Honor Award for Exemplary Services, DMA. And she is also interested in social work, has conducted cervical cancer screening camps, has been conducting regular CMEs in Dwarka, and has delivered lectures on adolescent health education and invited for guest lectures, panel discussion, and to chair the sessions in many national and international conferences. Welcome, Dr. Neeru. Now I welcome Dr. Rima. She is MS DNB, FICOG, MN AMS, and she is a professor of Obs and Gynae and fetal medicine specialist at Army Hospital, RRR, New Delhi, and she has a special interest in fetal invasive and high-risk pregnancy. She is an executive member of Society of Fetal Medicine, and she is a co-chairperson of the R subcommittee, and she is the chief of Army Staff Commendation, and she has Mr. S. Bhattacharya and Dr. Ganguly's gold medal, 42nd Annual Conference Association at AOGD Delhi, and Dr. Neera Agrawal's medal Best Paper, silver medal in 35th Annual Conference of AOGD Delhi. Welcome, Dr. Rima. Now I invite chairpersons to introduce our speaker, Dr. Rachna. Yeah, Dr. Rima, are you around?
Yes.
Yeah.
So we welcome Dr. Rachna. She is a very dear friend and a fantastic speaker, doing some fantastic work in fetal medicine. She's the director and senior consultant at Sonipat Fetal Medicine and Genetic Care, Sunehri Devi Hospital. She's the owner of the hospital, and she's doing some very good work in Sonipat. She's a visiting consultant at Apollo Hospital for Fetal Medicine. She's done a fellowship from FMF UK. She's the executive member and secretary general of FMF India. She's an approved examiner, and there are very few in our country who's FMF UK approved examiner for Anomaly certification in India. And she's worked extensively on the first trimester screening for preterm delivery in UK, collaborated with Apollo Hospital Fetal Medicine in various research projects during her fellowship. She's worked at AIMS also as a research associate, where she worked on combined screening for aneuploidies and preeclampsia in the first trimester. She's got numerous publications in international journal, and she's a great academician. She wants to do some good work, and she's extremely fine human being as well. So we welcome Dr. Rachna to take us through twin pregnancies today.
Very warm good evening to everyone. And thank you, Dr. Lima, for such a kind information, kind introduction. And thank you, organizers, for having me here to begin with the presentation. So management of multiple pregnancies with discordant anomalies. These cases can be sometimes very easy to counsel, but at times it is extremely difficult to manage and counsel because you exactly don't know whether you're doing the right thing, if you're advising for termination or reduction or expected management. So we would like to concentrate on the factors that help us to counsel these patients, what will be the right step for them to for their management, for having the healthy baby, to take home a healthy child, whether 1 or 2 or 3 or whatever is the best possible. Their wish has to be taken into account, what the parents think is important for them, and what are the pros and cons of each and every step. So if we have this kind of picture, you have a dichorionic twin pregnancy with one baby having a serenomelia and presenting as early as 12 weeks. I think it is rather easy to tell them, okay, they can opt for fetal reduction because they have presented early and the risk of miscarriage is going to be quite less. But sometimes you are facing this kind of picture where you have a monochorionic pregnancy, where one baby is looking absolutely fine, but the other has a subcutaneous edema and a mild pleural effusion. So kind of hydrops kind of picture, but this is a monochorionic pregnancy. So here you can't really offer reduction straight away. And also to say that just continue expectantly, you have to tell them what are their risks of having a spontaneous demise of one of the fetuses where the other fetus will also be affected. So what are the points to keep in mind in such a situation? First of all, the most important thing is that the chorionicity and the number of fetuses has to be accurately diagnosed. You have to make sure that it is correctly labeled as either dichorionic, where you can demonstrate a lambda sign in the first trimester, or a T sign. The difference is that you have the placenta dipping into the membrane here, the placental tissue, which will be lambda sign telling you this is a dichorionic pregnancy, or you have the membranes but no placental tissue going inside, showing you that this is a T sign indicating a monochorionic pregnancy. So you can have different types of combinations, like you can have dichorionic, triamniotic, where you have a MCDA pair and a separate fetus with a separate placenta. You can have a situation where you have a momo pair with a separate fetus, but with only one placenta. So all sort of situations are possible, and we see so many unique cases with artificial reproductive techniques. So it is extremely important that I have a good scan, first of all, to identify the chorionicity, number of fetuses, a good structural anatomy survey to identify what type of anomaly is there, right? So the counseling depends upon the chorionicity, the gestational age at diagnosis, the number of fetuses, association with the chromosomal problems, lethality of the problem, association with polyhydramnios, for example, anencephaly, which will lead up to polyhydramnios if we continue with the expectant management. In the monochorionic pregnancies, again, it will depend upon the indication and the gestational age, whether it is a discordant anomaly, it is a trap, or twin-to-twin transfusion, or selective fetal growth restriction. And also one should take into account, into consideration, the cervical length. This is one factor which we often forget before going for the management, whether the patient is already at a risk of premature delivery or a miscarriage in view of short cervical length. So the aim is to improve the take-home baby weight of the healthy babies. And if we look at the methods of reduction, the dichorionic, it is using the potassium chloride. But in monochorionic fetuses, you cannot use potassium chloride. So remember that, please always. The methods, you have a choice of interstitial laser, RFA, or bipolar cord occlusion. Now, RFA is emerging as the most popular method for fetal reduction in monochorionic pregnancies. So the risk of miscarriage in dichorionic twins, there was a seminal paper by Evans in 1994, which said that if there is a reduction done before 16 weeks, the risk of miscarriage is about 5%. And Apollo Center for Fetal Medicine also published this paper in Fetal Diagnosis Therapy 2021, where the fetal reduction was done in DCDA twin pregnancies in the first trimester on parental request. And there also the risk of miscarriage was about 5.7%. And after 16 weeks, as per Evans, the risk of miscarriage increases to about 15%. And the risk of prematurity, Ivan said that the gestational age at delivery is inversely proportionate to G8 reduction. So higher the G8 reduction, earlier is the gestational age at delivery. So later the reduction, earlier more the prematurity. Also, we looked up at our data in less than 16 weeks. If we were doing a reduction in the first trimester, the risk of prematurity was comparable to the singletons who never had any complication. The risk of prematurity did not increase if the reduction was done before 15 weeks. If we look at the monochorionic pregnancies, what is the risk of miscarriage or prematurity, and also very importantly, the demise of the co-twin? So this paper by Greg Bryan in Prenatal Diagnosis 21, they analyzed about 105 monochorionic pregnancies undergoing selective reduction. This was a 20-year data. And they also analyzed that RFA was their most used procedure with the minimum complications. And in the maximum number of patients, they have used RFA as a mode. And their miscarriage rate at less than 24 weeks, overall the miscarriage rate was 10.5%. And it was maximum in the cases undergoing laser, but these cases were done, lasers were done practically more for TTTs, which were not amenable to not to fetal, they could have only fetal reduction, but not the vascular anastomosis coagulation. So these were very complicated cases. And if we look at the cumulative risk of prematurity in these monochorionic pregnancies, the risk of prematurity is almost 55%. And before 34 weeks, the early preterm is 37%. And they also said that reduction using RFA was preferable because it was simpler and faster. So the amount of time that you spend in a monochorionic pregnancy doing a reduction, that matters a lot. And it was associated with less preterm birth, the RFA. And they said that maternal fetal complications, including the co-twin demise, PPROM within 24 hours, they were comparable between all three techniques. And fact that it being a monoamniotic pregnancy, the gestational age at intervention and the procedure, additional procedures done at the time of cord occlusion, for example, cord transection, amnio drainage, or amnio infusion, that did not impact on the outcome. So what I want to say here is in monochorionic pregnancy, we are not really sure that what is the appropriate gestational age for doing the reduction. So any gestational age has a high risk of miscarriage and prematurity in monochorionic pregnancies, but it is feasible. And here we have about outcomes of about we had 15 cases who underwent interstitial laser between 11 to 14 weeks at Apollo. The outcomes are available for 13 cases. And in these cases, we had only one miscarriage out of 13, which was 9 weeks later. And there was loss of co-twin in one of the pregnancies where it was an MCTA triplets, and 2 of the fetuses were reduced. So that pregnancy had a loss of co-twin. And preterm delivery less than 32 weeks was 0. In one of the pregnancies, the surviving fetus had aplasia cutis. So these are very small numbers, 13 cases only. But even in the first trimester, the interstitial laser, here it looks like a good outcome, not a really bad situation for the parents. So what I want to say here that in dichorionic, if you are having a situation where you have the first trimester fetus presenting with a discordant anomaly, it is safer to say that they can undergo a reduction using a potassium chloride because the risk of miscarriage is 5% and risk of prematurity is not increased if you are doing the first trimester reduction. Whereas in the second trimester reduction, the risk of prematurity will be about 15%. And the risk of prematurity will also be higher if the gestational age at reduction is higher. Whereas for monochorionic, the risk for miscarriage remains about 10% with a very high risk of prematurity, whatever be the gestational age. And the method that you use for reduction depends on the expertise of the referral, which fetal medicine center they have gone to, what are they comfortable with. So if you have a pregnancy which has discordance for anomaly, refer to fetal medicine center, establish the chorionicity. If it is a dichorionic pregnancy, and you have a problem which is treatable and not chromosomal, or it is lethal but not associated with polyhydramnios, one can consider expectant management. If it is lethal associated with polyhydramnios, whatever be the gestational age, I think it is better to offer a reduction using potassium chloride. And if you have a non-lethal chromosomal abnormality or a CNS abnormality where parents are definitely not eager to continue with the baby, then you look at the gestational age. If it is less than 16 weeks, you can offer the reduction. If it is more than 16 weeks, one might consider late selective reduction at 32 weeks after giving steroids. In monochorionic pregnancies, if it is a condition like TTS or selective FGR, the management will be as per protocol. And in case of CNS anomaly or associated with polyhydramnios or TRAP, one should counsel for reduction after counseling for the risk for prematurity and the miscarriage. And the options are these three. And if it is lethal but not associated with polyhydramnios or a treatable anomaly, then expectant management is a better approach, because if you do a reduction in these cases, you are anyways not improving the outcome, because the risk of miscarriage and prematurity in monochorionic is pretty high. So if we look at this case, this was a dichorionic twin pregnancy where one of the fetuses had a tetralogy of fallow kind of picture on the first trimester scan at 13 weeks. We could see overwriting aorta and a very small pulmonary artery here. Only aorta was nicely visible. So a CVS was done, and this was confirmed to be trisomy 21, and they opted for a fetal reduction. So the second baby was delivered at term vaginally and had a healthy outcome. And whereas if you look at this patient, this was a monochorionic pregnancy, and we were following right from 13 weeks, where the first presented with a discordant CRL. This baby then at 15 weeks also showed a cardiac abnormality. And then we saw hemivertebrae, and we also saw a unilateral lung agenesis. Then they kept on continuing with the expectant management, because we thought this heart didn't look nice to us, and probably this will not survive. And the cervix was also like 30-31 millimeters. She had 2 episodes of spotting in the first and early second trimester. So at 31 weeks, patient developed polyhydramnios in this sac of the smaller twin. And then at 34 weeks, she had a PPROM, and then underwent a spontaneous vaginal delivery. The first was a healthy one, and the second baby was born and confirmed to be a case of tracheoesophageal fistula, had multiple hemivertebrae, unilateral lung agenesis, and succumbed within 24 hours. So this case was managed with expectant management. So again, the take-home message is that if you have a monochorionic pregnancy, it is better like not to intervene too much if you can avoid it. But if yes, it is necessary to intervene, for example, in a case of TRAP or NK-free, then you must refer to an experienced fetal medicine center for proper management and counseling. Thank you.
Thank you, Dr. Rachna, for those
Dr. Gitanjali.
Wonderful inputs. Diagnosed anomaly after 16 weeks.
Dr. Gitanjali, are you around? Okay, I think Dr. Vandana, you can share your experience, because you have vast experience with both fetal reduction, monochorionic and dichorionic.
So I think for our audience, the take-home message is that establishing chorionicity in the first trimester is very important, and whenever we see twin pregnancy, we should be clearly labeling them as monochorionic or dichorionic as early on in the pregnancy, because it's not just if there is a discordant anomalous twin, any other complication or any other management that we have to deal with later in the pregnancy, the establishing of the chorionicity is important. So one is that, and yes, when you do identify a problem, the right person who has experienced in intervention, etc., their opinion can be taken liberally once you face that situation. So defining the anomaly, deciding whether it will be associated with lethality or not, deciding whether there is associated chromosomal abnormality, should you do intervention for looking at chromosomal anomaly, or should you straight away do fetal reduction associated polyhydramnios, how much it will impact the preterm labor. So those are complicated decision making, sometimes keeping the background of the patient in mind, keeping their infertility status, etc. in mind. So I think a lot of thought goes into what decision you make for a particular family, and it should be well thought of before you make any irreversible decision.
So thank you, Dr. Vandana, for sharing such a your great experience. And with this, now we are late in our session, so hurriedly I will we'll move on to the next session on the chromosome, on the fetal testing. And so I would like to invite our chairpersons, Dr. Shilpa Ghosh, who is the Director of Ops and Gynae at Akash Healthcare, Dwarka. She has done her senior residency from LHMC, more than 20 years of experience, and previously she was the Director at Ops and Gynae, Fortis Vasant Kunj, and associated with reputed hospital like Columbia Asia Venkateshwara, and her special interest is high-risk pregnancy. Welcome, Dr. Shilpa.
Thanks.
Yeah. So now I invite Dr. Bhavna Anand, who has done her MBBS and MS and FIC MCH, and she is working as a consultant in Department of Fetal Medicine, Manipal Hospital, Dwarka, New Delhi. And her field of interest is obstetric sonography and various fetal interventional procedures. She's a distinguished fetal medicine specialist trained at SGPGI Lucknow, and she's an expert in handling at high-risk cases. And she also has an outstanding academic career with several publications in various national and international journals, including Fetal Diagnosis and Therapy and Journal of Maternal, Fetal and Neonatal Medicine. And welcome, Dr. Bhavna.
Thank you, ma'am. Good evening, everyone.
Yeah, so now I request chairpersons to invite our speaker, Dr. Sunita. I think Dr. Sangeeta Dr. Sangeeta is also a chairperson.
Yeah.
Dr. Sangeeta?
Yeah.
Yeah, Dr. Sangeeta, I think they showed your CV earlier. So
Yeah,
Dr.
no
Sangeeta,
issues.
everybody knows. She is a professor at MAMC, Delhi.
I think Seema can introduce Dr. Sunita Bisharnia, who's a very dear friend and is a senior consultant in the Department of Genomics and Genetics at Sir Gangaram Hospital, one of the premium institutes in the field of genetics in the private sector. So she has a vast experience in inborn errors of metabolism, and she has a lot of publications. She's a founding executive member of Indian Society for Inborn Errors of Metabolism, and she's on the editorial board of Indian Pediatrics and Journal of Fetal Medicine. And she has current research work in various aspects like genetic etiologies in childhood neural regressions, that is lysosomal storage disorders, and many more. And I won't take more time and come between Dr. Sunita and you. So with this, we hand over to Dr. Sunita to deliberate today with us.
Thank you so much, Dr. Sangeeta, for the kind words. And thank you, Dr. Shilpa and Dr. Bhavna and Seema. I would really like to thank the AOGD and the organizing committee for allowing me to be part of this very nice meeting. My screen is not full.
Very colorful screen.
Let me just open my slide. So the job assigned to me is to tell you about incorporating chromosomal microarray analysis and next generation sequencing testing for ultrasound detected anomalies in our clinical practice. So at the outset, I would like to give my acknowledgements to Seema, Dr. Sangeeta and AOGD, all organizers, all my colleagues, Sir Dr. Verma, and all my past and present fellows, and all the referring doctors who are from Delhi NCR, and of course patients. So I'll just start my presentation. Let's go back to 60 years ago when we were very excited by finding the chromosome. So with the discovery of the chromosome, the history of genetic testing actually started. So we have come a long way from just identifying the chromosomes to identifying the DNA structure, as well as coming down to a single point of one base pair. So these are the genes that are situated on the chromosomes. So this is all about that we do in genetics. So what is the lifetime burden of genetic diseases? I borrowed this slide from Dr. Verma. Basically, throughout life, as life goes on, we do encounter a lot of genetic conditions, but they seem to be clustered and they do have some pattern. So like, for example, immediately at birth or prior to birth, which is the antenatal period, we see a lot of morphogenetic abnormalities like the malformations, as well as other lethal abnormalities. So if we just focus on this part, then we know that congenital malformations are not that rare. 1 in 50 births will have a congenital malformation, and 1 in 200 births will have some kind of a chromosomal abnormality. So it is quite a huge burden. So there's an interesting study published in 2017 in BMJ from a cohort in Utah in USA, where more than 2.5 lakh births were studied, and the birth defects were noted. So there were about 5,500 birth defects, constituting about 2%, of which, if they were to go to the etiology, only 20% had some kind of a known etiology, whereas 80% were left without any etiological basis. So amongst these 20%, the group identified a lot of chromosomal abnormalities, like you see trisomy 21 being the foremost, the most common, and some other single gene, as well as aneuploidies, even structural abnormalities of the chromosome. So majority of them were chromosomal, like 15%, and about 4 or 5% were also there for single gene, and a handful of them were due to the teratology. So basically, let's come down to genetic testing for fetal anomalies. So we have also come a long way in genetic testing, starting from the conventional karyotyping, which is basically a study of picture of all the chromosomes in our body, to now well into practice standard of care, which is the chromosomal microarrays. So what difference does it make? Basically, it's a much zoomed in picture of a chromosome. So like here, this is a chromosome, and one is able to see all the very small, minute areas of this chromosome by using a microarray. So it is a much more magnified picture, and it carries much more sensitivity. So versus chromosomal abnormality, we also have some single gene abnormalities, which by convention we detect using Sanger sequencing technology or some kind of targeted testing. Basically, it is an old method, but it still comes into use when we have some specific etiology. Versus today, where a majority of our single gene genetic testing is done by next generation sequencing, which is basically multiplexing all the Sanger, you can say that. So one could choose any number of genes within the same test, right from a panel of say 4 or 5 genes to 1,000 genes to all the 20,000 genes, which is the whole exome sequencing. So it's a very useful, cost-effective, and not a very time-consuming technology. So we've just learned by cases. This was the simplest of the case. A 25-year-old presented in her second pregnancy at 19 weeks, and her reason for referral was a hypoplastic nasal bone. So basically, her NT scan had been all right. So she chose to go for amniocentesis after genetic counseling, and her genetic test, basically the FISH test for all the common aneuploidies was normal, and so was the karyotype. So basically, this was a normal study of the chromosome, and more importantly, the Down syndrome had been ruled out, and she was able to successfully continue and complete her pregnancy. So with the issue of a nasal bone, basically a study was carried out at our center. Dr. Dash was there, and we chose close to 100 patients and divided them into isolated and those with some abnormalities. So within the isolated group, both the absent as well as the hypoplastic nasal bone group had about 10 to 12% of diagnostic yield. Majority of them were aneuploidies. As opposed to the isolated nasal bone, if there was any additional abnormality on the ultrasound, then the diagnostic yield actually rose about 3 to 4-fold, again majorly with the aneuploidies. So, but if you, so basically if there is any other additional finding, whether it is an abnormality on the ultrasound or whether it is due to a biochemical screen which shows high risk, it does increase your risk for chromosomal abnormality. So just going through the common aneuploidies, trisomy 21, 18, and Turner syndrome, we move on to more complicated cases. So 12-week-old ultrasound with a nuchal translucency of 3.1, which was way above the 95th centile. So the couple, after counseling, chose for invasive testing, a CVS, and basically microarray analysis showed some abnormality. So what was the abnormality? Basically, it was the chromosome 22, the long arm 22q, and the subband 11, and there was a deletion of the size of about 2.7 megabases. So basically, what we had here was a 22q microdeletion syndrome. So this 22q microdeletion syndrome, or DGeorge or velocardiofacial, it has many other names. It is the most common microdeletion syndrome with an approximate incidence of 1 in 2,000. It comes with very wide variation, even in the same family. It comes with the spectra of malformations, like from the typical cardiac, Dr. Smith Mishra has very nicely told you, and few others like palatal and skeletal and any other. Along with the extracardiac, there are so many other systemic abnormalities, right, going down to adulthood, where they can actually present with psychiatric illnesses or autoimmune. Interestingly, 10% of the individuals harboring this deletion do not show any abnormality. So it's important even for counseling the couples when they have encountered this in their baby. So at Sir Gangaram Hospital, we had undergone a study on increased nuchal translucency for about 2 years. About 200 pregnancies were recruited, and they were divided into an NT of between 95th to 99th and NT of more than 99 centile. So what we found is that abnormal chromosome or karyotypic or CMA abnormality were present in 15% of these cases, where the NT was less than 99 but above the 95th. And this percentage rose to 40% when the NT was more than 99 centile. So another case, this baby with a fetal multiple anomalies was detected on ultrasound. So this was at 19 weeks. The anomalies were a cleft palate and microretrognathia, and the baby was of a primigravida who had an otherwise uneventful pregnancy. Her maternal screen for aneuploidies had been normal. There was no family history. There was no consanguinity. So she was provided with genetic counseling, and the couple opted for a termination of pregnancy followed by genetic testing. So the fetus was received by us for an autopsy. On examination, the fetus was noted to be dysmorphic. There's this hypertelorism, the broad root of the nose, the microretrognathia, and there was a cleft palate, and there was some contractural malformation deformities in the legs. So a chromosomal microarray was performed, which detected a large deletion on the P arm of chromosome 4, and thus diagnosis of Wolff-Hirschhorn disease was made on this baby. This was another chromosomal abnormality. So Dr. Meena Lal, who's the head of our cytogenetics, has performed this study and published. So basically, just to highlight the diagnostic yield of the microarrays as well as the karyotyping in all the prenatal diagnosis cases. And basically, I want to just get your focus here that the diagnostic yield was the maximum when it came to an abnormal fetal ultrasound. And there was a stark difference with whether the couple opted only for a karyotype or when the couple had opted for a microarray as well. So the microarray does give an additional diagnostic yield over and above the karyotype because of its increased sensitivity. Now switching gears, this was a family that presented to us at the 4th pregnancy, having lost 2 more previous pregnancies with similar affection. The fetuses had occipital encephalocele, and AV septal defect, a cystic enlarged kidney, and some polydactyly. So this fetus, because of these ultrasound findings, which were quite severe, the parents opted for a termination and followed by a whole exome sequencing as a trio. So basically the fetal sample as well as the couple was sent. This was done under research. So the finding was that the proband, the fetus, was carrying a homozygous pathogenic variant in a gene called MKS1, thus giving the diagnosis of Meckel-Gruber syndrome. Both the parents were heterozygous carriers of this particular variant. So this variant was further verified on Sanger sequencing and thus labeling the diagnosis of Meckel-Gruber syndrome. So after the diagnosis, it became very clear and the couple received accurate counseling of this being an autosomal recessive disorder with a risk of 25% happening in each subsequent pregnancy. So the couple planned another pregnancy and presented to us at 11 weeks with this previous history and a diagnosis in the baby, and thus were able to be offered prenatal testing by way of chorionic villus sampling. And luckily, the fetus turned out to be normal and not affected with Meckel-Gruber syndrome. So another case, a second gravida having terminated a previous pregnancy for hydrocephalus, presented to us at around 18-19 weeks with an anomaly scan finding of hydrocephalus, posterior fossa showing direct communication with 4th ventricle and cisterna magna. So there was a possibility of a Blake-Bouts cyst, but then there were many other extracranial abnormalities, such as the right multicystic dysplastic kidney, as well as a CTEV on the right side. So the couple again opted for a termination after the genetic counseling and was taken up for an autopsy. The baby did not have any external facial dysmorphism. There were contractures of fingers and bilateral elbow joints. There was right CTEV, and there was a rocker bottom foot. So internally, there was the right kidney was very, very enlarged, and there was cysts that we could see in the cranium. There was partial agenesis of the corpus callosum. There was ventricular dilatation, and in the posterior fossa, there was an enlarged cisterna magna and a Dandy-Walker malformation. So going through the process of fetal autopsy, it was a multiple malformation syndrome. So of course, the first genetic test that was done was a chromosomal microarray, which came out to be normal. So having had a recurrence of a similar problem, this was perhaps a single gene disorder, and therefore a whole exome sequencing as a trio was performed again on research basis on this patient. And in the fukutin gene, there was a homozygous pathogenic variant, premature termination codon, in the gene, which then gives the diagnosis of Walker-Warburg syndrome. Is another autosomal recessive disorder with the risk of recurrence, and the same thing was informed to the couple. And Another pregnancy where there was a fetal demise at 30 weeks. This in the index pregnancy, there was really no history of any exposure. A 20-week anomaly scan had been normal. And she did have another scan at 28 weeks where the abnormalities noted were short limbs, bilateral hydronephrosis, and oligoamnias. So there was no consanguinity and there was no significant family history. So after the termination of there was an IUD, so the fetus was delivered and sent to us for autopsy. There were some external dysmorphic features, but very strikingly, there was a short and narrow chest, and the diameter of it measures only about 3rd centile. There were short humeri as well, so there was rhizomelic shortening of all the 4 limbs. There was polydactyly noted, and there was also syndactyly between 2 and 3 toes. And here in this case, radiograph became very important. So the fetogram showed multiple skeletal abnormalities, such as the high riding clavicles, a short and narrow thorax with short ribs, bell-shaped thorax, a metaphyseal widening, a rhizomelia, polydactyly, a short iliac bones with a medial spur. So all these findings were quite characteristic of a disorder called short rib polydactyly syndrome. And this was type 1. This is all autosomal recessive disorders, and genetic testing did prove that. Coming to the last case, this was a baby who's referred to us after termination because of major skeletal abnormalities. The baby had short limbs on ultrasound. They were short and mal-shaped femora, as you can see in the radiographs. There were thin ribs. And there was also a note of fracture of the humerus. So after autopsy, fetal genetic testing was performed, and the baby was diagnosed to have osteogenesis imperfecta. There was a pathogenic variant in the COL1A1 gene, which happens in 90% of osteogenesis imperfecta. So basically, the role of genetic testing in antenatally determined fetal anomalies is mainly to confirm the diagnosis, to provide accurate genetic counseling and determination of the risk of recurrence to the family. And this is the essential prerequisite to facilitate or to enable either prenatal or even pre-implantation genetic diagnosis. So we must remember that each case is different, because you might think that, oh, this could well have been a chromosomal disorder, but very similar disorders can have even single gene. So there is no really universal formula. So our approach as a geneticist is to evaluate when the couple presents to us. So first of all, to take all the evidences, the history examination, and then evaluate whether the pregnancy is viable, whether how the prognosis is going to be with or without the genetic diagnosis. So for example, for all the major malformations where you can already see that it is not compatible with life, then the couple can be offered a termination of pregnancy, provided, of course, it's the uptake of the couple. And so, but for certain anomalies, as Dr. Smith Mishra has already told, with an example of cardiac defects, one should be able to explore whether they are amenable to surgical treatments. So in such cases, one could do genetic testing in order to rule out or differentiate it from the syndromic causes, which have an altogether different prognosis. So at our center, we have devised a sort of a protocol. So these are pregnancies who are to be terminated. So one could actually consider genetic testing even before termination, because it gives a better yield. We get a better tissue for DNA and cytogenetic testing, but it depends upon the couple. So after the delivery of the fetus, one could offer a full or even a partial autopsy. So this could entail just the external examination with photographs. One should incorporate radiological, at least an X-ray, if not CT and MRI, and genetic testing, which involves all the aspects like cytogenetics, molecular genetic testing, or sometimes even biochemical genetic testing. And ultimately, at the end of it all, one should conclude and sit down with the family to counsel them again after the final diagnosis has been achieved. So these are the various indications for fetal autopsy, as the august audience already knows. The majority of them, you can see, are because of the malformations. So just to conclude, the fetal malformations, whether detected or not in the antenatal period, they are important and they are common. And it's the major malformations that need closer evaluation. So not just simply a polydactyly or a muscular VSD, but at least they should be evaluated for clinically, radiologically, and also with genetic testing. History is very, very important in such cases because they give very significant clues to a genetic etiology. Like, for example, if there's consanguinity and there is a risk of there is a recurrence already, then it is likely to be a single gene autosomal recessive disorder. And if there's bad obstetric history with multiple miscarriages and even in the extended family, it could be a chromosomal cause. So deal with each case individually, offer genetic testing in all indicated cases, irrespective of uptake, because one usually shies away from telling about the testing because of cost constraints, etc. But at least put the information through, and it is the couple who will decide what they want to do. And of course, this is also part of genetic counseling. And it is critical, the testing is critical for prognostication. And of course, we know that genetic testing, there's no single mantra. One has to identify and go with the flow and maybe follow protocols wherever they are. Thank you so much. In my discussion.
Thank you, Dr. Sunita, for such a wonderful and enlightening talk. And thank you, Dr. Seema, for such an academic treat with such important topics being covered so well. Dr. Sunita is quite experienced, and I mean, so many of our patients from Dwarka, I think, land up in Gangaram with her, and with her expert advice, as she has rightly mentioned, autopsies and other tests are done. I would just like to, as an ACOG, because I am a gynecologist, not a geneticist, so ACOG does recommend that for structural abnormalities which are there on ultrasound, then CMA is better than karyotype. So am I correct when
yes,
I quote
yes,
ACOG?
yes, this is now the standard of care. So in the US, in fact, karyotype has been given away because it is very tedious and labor intensive. So it's the CMA that has replaced the karyotype majority, even in children with intellectual disabilities. So many indications have gone to CMAs.
CM, because patients do come to us as a first point of contact, and then they ask us, our geneticist has told this, and then we are supposed to be on the same page. So I was reading the ACOG guideline, and they clearly say for structural abnormalities we all should be on the same page. CMA would be better than the karyotype, and for structurally normal antenatal patients, the fetuses, they say either can be chosen. Ma'am, just one, NGS is on an experimental basis in India, because they do say that it should be only in clinical labs and trials and not a part of routine testing. So how is it positioned in India?
There's a difference here. NGS is just a methodology, it's a technology. So whole exome sequencing has come into the clinics. It is very well established and it's no longer experimental. So it should be offered wherever indicated. But it's the whole genome test, which is not really there. It's there in many situations, but not here, not in the prenatal scenarios.
So WES is a well-established thing, even in India,
but one has to clear the indications.
The turnaround time for that, though they have mentioned, may be more, and the cost may be more. So all of us should refer the patient to a genetic counselor and not do any counseling ourselves, because there are so many advanced tests, and NGS or WES can detect much more problems than what our standard FISH and karyotype would. So wonderful talk, I think, and we've learned a lot from you. Thank you.
So Vandana, would you like to add something, or should we move on to the next?
Just one line, that you can do microarray on the fetus, but you should do the NGS on the index case. And when you have the mutation in hand, when you know, confirm it, correlate with phenotype, only then you offer the prenatal Don't go for prenatal testing with a blind, just do NGS without having the index piece worked out. That is the important message.
The trio sequencing.
Yes.
So NGS is not indicated in all cases.
Yeah.
One should.
Index case diagnosis must be established first.
Must be established
for
the prenatal diagnosis.
For the prenatal diagnosis. Yeah. So Bhavna, I think you can unmute yourself and speak if you want to add something. Or
Yeah. Thank you, Dr. Sunita, for such a beautiful talk and beautiful pictures. Genetic technology has improved a lot over the years. Besides karyotype, in which we study only the structure and number of chromosomes, we can now do microarray, in which we go some microscopic level, and to the NGS, in which we can count all the base pair also. So the technology has improved, and but I just want to add a point that in antenatal cases, a pre-test and post-test counseling is very essential to know the results of the test, what test we are doing, what is the limitation, and what are the benefits of this test.
Absolutely.
So thank you, Dr. Sunita and the chairpersons for this session. And it was really an excellent lecture. Now we move on to the next session, which is by Dr. Prashant Jain. I invite chairpersons for this session. Shivam. Dr. Gaurav Kumar. He is a consultant of Department of Pediatrics and Neonatology at Venkateshwara Hospital, Dwarka. And he has more than 10-year experience in the field of pediatrics and neonatology with special interest in NICU. And he has lots of publication in Index Journal and presented multiple papers in national neonatology conferences. Welcome, Dr. Gaurav. Next, please. So I have pleasure to invite Dr. Vikas Taneja, whom I know since my FMRI days. And currently he is associated with Manipal Hospital, Dwarka as an HOD pediatrics. His major achievements is in the field of the pediatric simulation since 2015. And he is a certified PICU teacher of College of Pediatric Critical Care since 2013 and certified pediatric advanced life support instructor since 2008, and more than 25 years of experience in the field of pediatrics and pediatric intensive care. And he has received awards, Sir James Flett Gold Medal for Best Paper in Social Pediatrics at the 37th National Conference of IAP January 2000, and Best Paper in Pediatric Critical Care Section at the 10th Annual Conference of the Indian Society of Critical Care Medicine, February 2004, and has published more than 15 papers in international and national journals, and has written 14 chapters for various textbooks, and have presented 10 papers in various national conferences, has more than 100 citations, and his special interest is pediatric sedation for short procedures and pediatric ventilation, basic and advanced. Welcome, sir. And I have a pleasure to invite Dr. Manisha, whom I know since my MBBS days. She has been my senior in my medical college, and she is currently a director professor at Department of Obs and Gynae, Lady Hardinge Medical College, New Delhi. She has played a pivotal role in starting fetal medicine and genetic lab facility at the institute. And I probably, since knowing her since ages, so I know that this is one have been the landmark in a government institution, and that too from an obstetric background to start a genetic lab facility at a government institution. So congratulations, ma'am. And has done research on early prediction of hypertension in pregnancy. She is actively involved in various research projects on preeclampsia, placental profile markers, birth defects, and stillbirth, and has numerous publications in this field. Welcome, ma'am. Now I invite chairpersons to introduce our speaker, Dr. Prashant Jain. Dr. Gaurav, are you around?
Yes, ma'am, I'm around. Good evening, everyone. Thank you, ma'am. First of all, I would like to applaud the efforts of organizing team for having this wonderful conference of different topics from the fetal medication, especially Dr. Seema, ma'am. Now I would like to introduce our speaker of the session, Dr. Prashant Jain. Dr. Prashant Jain is a very well-renowned pediatric surgeon, and he is working as a director of pediatric surgery and pediatric urology in the BLK Max Super Specialty Hospital, New Delhi. He has been trained in many premier institutes in India and abroad as well, like KEM and Glavati Hospital. He has also work experience in pediatric urology in Great Ormond Street, London. He has special expertise and vast experience in pediatric urology and pediatric minimal invasive surgeries. He has been presented like more than 50 publications in pediatric surgery and pediatric urology in various national and international journals. Now I'd like to hand over the session to Dr. Prashant Jain. Thank you, sir. Thank you.
Yeah, a very good evening, everyone. And thank you all the organizers and especially Dr. Seema for inviting me in this prestigious workshop. And basically, I will be presenting today regarding the postnatal management, postnatal surgical management of the fetal malformations. So I hope you can see my presentation.
Yeah, Dr. Prashant, it is visible.
Yes, Dr. Prashant, we can see.
Yeah, okay. So fetal anomalies, as you all know, are one of the very leading causes of the deaths in newborn, and they causes long-term disabilities. And even as per WHO, they are the second most common causes of the fetal demise and the newborn deaths after the fetal hypoxia. And with the advancements in the various imagings, postnatal, neonatal care, and the advancements in the surgical techniques, definitely there has been a better outcome in the management of these fetal anomalies. But most important challenge for us as a clinician is the adequate counseling and the prognosis of the parents, because the parents, they always have a lot of anxiety regarding the evaluation and the management of these fetal anomalies, especially if surgery is involved. So very important is to counsel them and to do timely evaluation and intervention so that we can have a good outcome. And for that, what is required is basically establishment of a multidisciplinary consultation system. So problems, it's a wide range of spectrum. And I won't be able to cover all the anomalies in this session. So what I have decided is to just, I will brief you about one very interesting case of a large fetal neck mass and some of the urological anomalies which we very frequently come across in our routine practices. So this was a 30-year-old female who was G2, P1, and L1, presented with an antenatal scan at 30 weeks, which was showing a large multiseptated, predominantly cystic mass of more than 10 centimeters, which was involving the neck and extending into the superior mediastinum with fluid debris and few echoes. AFI was 23 centimeters, suggestive of polyhydramnios, and we had a provisional diagnosis of either it could be a lymphatic malformation or a cystic teratoma. So to have a better imaging and to have a better idea of the airway and the neck and the mediastinal structures, we ordered for the fetal MRI, and the fetal MRI showed that it was again a large cystic mass of around 15 by 10 centimeters, involving the neck and extending into the mediastinum, and also it was compressing the airway. So these are some beautiful pictures of the fetal MRI which revealed that there was a compression of the trachea and also the displacement of the mediastinum. So performing then planning the delivery in this patient was a real challenge for us, because the airway was involved and we may not be able to intubate the child after delivery within a limited period of time. So basically we had two options. Either we should go for the elective cesarean section and do neonatal resuscitation after cord clamping, which can be very difficult and can lead to the hypoxia. And the better option was to go for the exit procedure, that is the extracorporeal intrapartum treatment, which would have been an ideal approach in this child because of the airway involvement. So we did a lot of brainstorming. The first thing we did was to constitute a team, and the team involving all, including obstetrician, neonatologist, myself, pulmonologist, ENT, all of us discussed about the case because this was something new for us, the management of such kind of case. And then we decided that the best option would be to go for the exit procedure. So exit basically is a securing the airway of the fetus with intact placenta circulation. So feto-maternal circulation is intact, and during this intact feto-maternal circulation, the airway of the fetus will be secured. Now, this is not like any other cesarean sections. So this will be done under general anesthesia along with the uterine relaxants. The main aim would be to prevent the cord compression and to prevent the premature separation of the placenta so that we can buy enough time to secure the airway. Fetal immobility is also required, so fetal anesthesia needs to be given during manipulation. But at the same time, we should keep in mind that whatever procedure we are performing should cause minimal maternal morbidity. So we explained all the benefits, risks, and advantages and disadvantages of the procedure to the parents. We explained the risk of the neonatal hypoxia, fetal demise, and even the failure of the procedure. Maternal risks like bleeding and pulmonary edema were also explained to the parents. Also, we told them that this is not going to be a simple condition. Even after the delivery, there will be a lot of challenges because the child might require a surgical excision, sclerotherapies, or tracheostomy. So another challenge for us was to decide for the timing of the delivery, because if the ideal situation would have been to perform delivery somewhere around 37 to 39 weeks, but there can always be the risk of premature delivery because there was a polyhydramnios, risk of hydrops. The patient already had a history of premature delivery. There was a history of cervical incompetence, and there was a history of leaking. So keeping in view all these factors, there was always a risk that the patient can end up with a premature delivery. So a very close monitoring it was required, and we decided that we will plan for the delivery somewhere between 37 to 39 weeks. And we planned all these steps. Each and every steps was precisely planned. Work was assigned to each member of the teamwork. OT planning was done with all the equipments, and the necessary instruments were procured for the successful procedure. Now, as far as the anesthesia is concerned, because it is done under general anesthesia and uterine relaxant, there is always a very high risk of bleeding at the time of hysterotomy. So the adequate amount of blood is required, monitoring of the blood pressure and normothermia, prompt replacement of the losses. All these tactics were planned for the successful management. Now, obstetric planning was done. Patient positioning was planned, adequate exposure, need for uterine relaxation, hemostasis at the time of uterine incision. The very important thing was to maintain the amniotic fluid through amnio infusion and minimal handling of the cord and the fetus at the time of the procedure. Fetal management, fetal also requires anesthesia because we don't want the child to be mobile at the time of the procedure. So once you deliver the child, the fetal anesthesia needs to be given, which includes the fentanyl, muscle relaxant, and atropine. IV cannula needs to be secured. For the monitoring of heart rate, if required, pediatric cardiologist should be available for echocardiography, and adequate amount of blood products and crystalloids should also be kept ready for the resuscitation of the fetus. Now, the most important step was the airway management. So the first step, we planned that we will try initially for the oronasal or nasotracheal intubation. If it succeeds, then we can always disconnect the cord and separate that and can shift the child newborn in the nursery. If it is not successful, the second step would be to use rigid or a flexible bronchoscope so that we can secure the airway with the help of a bronchoscope. Even if the second step doesn't succeed, then the final option would be doing a tracheostomy, which might also require a partial resection of the mass. So this is all, the planning was done step by step, but most important in the planning was to save as much as time as possible, because you have a very limited period of time when the fetal-maternal circulation is intact and you are performing a procedure. So we allocated time for each and every step. The first step 1, we allocated around 5 to 10 minutes. Step 2, around 5 to 10 minutes, and tracheostomy around 10 minutes. So this is what the planning was performed. And if you review the literature, the success rate in such a way of planning is almost as high as 97%. So 97% of the times you will be able to secure the airway by one or the other means. Operation theater was kept ready with 2 operation theaters, anesthesia trolley, cesarean trolley, bronchoscopes were procured for the neonatal intubation, tracheostomy sets, and all accessories which were required were arranged. To secure the airway, our neonatologists, they had made the arrangements for appropriate size of tubes and appropriate size of the blades, LMA and everything. And even the tracheostomy tube was kept ready. Now because we want to save the time and we don't want to, we want the procedure to be done in the appropriate time duration. So we did the mock drill regarding the positioning of the patient, arrangement of the operation theater, ergonomics, and the instruments. Ultrasound was done to look for the fetal position of the placenta and the liquor. Blood and blood products were arranged for the mother and the fetus. All sorts of monitoring was kept ready for the during the time of the procedure, because we don't want to take any risk for the mother. Now, this is what the OT setup looked like, and this is ergonomics which we arranged at the time of the procedure. And I will just show you a small clipping of the procedure. So this is a wide, low transverse incision was given, and a formal laparotomy was performed as we do in the normal cesarean section. The incision is wider as compared to the normal CS section. Once you reach the uterus, the risk of bleeding is very high, because the mother is already receiving general anesthesia and the uterine relaxants. The ideal thing would be to use the uterine staplers, but unfortunately we could not procure the uterine staplers. So the uterus was opened layer by layer using the reefing knots to prevent any risk of bleeding and hemorrhage. So as you can see, our obstetricians were opening the uterus in layers, and you can see that the bulging amniotic membrane and the amniotic fluid which was drained out. So once the amniotic membrane was opened, the fetal head was delivered, and as you can make out, there is a huge neck mass was there. Immediately after the delivery of the fetus, on the right arm, the fentanyl was given, and the amnio infusion with ringer lactate was started. The purpose of amnio infusion was to maintain the adequate uterine volume and to prevent the premature separation of the placenta. And as you can see that the fetus head is delivered, and the one person is instilling the ringer lactate fluid for amnio infusion. Now our neonatologist came into the picture for the intubation. And obviously it was tough because it was a large mass involving the neck and extending even into the mediastinum. And patient positioning was again a challenge for us. But fortunately, our neonatologists were able to intubate, could able to locate the vocal cord and were able to intubate the fetus in 2 attempts. So once the child was once the fetus was intubated, the cord was separated, and then the child was shifted in the nursery. So as you can see, all fetal monitoring was also done. The pulse oximeter was connected, amnio infusion was continued, and the IV cannula was also placed in position. So this is how the intubation was done. You can make out there's a huge neck mass which was seen there. Endotracheal tube was fixed, and then the cord declamping was done, and the child was shifted in the nursery. So the child was kept on bag and tube ventilation and was maintaining saturation of around 100% gradually. Initially it was 70%, gradually it was around 100%, and was transported in the NICU on ventilator. So total duration of this procedure was around 91 minutes, including the induction, cesarean section, and the extubation of the mother. The head out to cord clamp time was 14 minutes and total intubation time was around 75 seconds. So, so almost 75 seconds was taken to intubate the child, but which could have been very risky if the child would have delivered in as per the normal cesarean section delivery, because by 75 seconds, we could have, the child could have the fetal hypoxia and the brain damages. So after delivery, the child remained stable on ventilator. The weight of the baby was around 2,700 grams and all the vitals were stable. We tried one extubation also, but we were not able to extubate the child. And so we planned that we will go for the debulking of the lesion around the trachea so that we can able to extubate the child. And if we are not able to extubate the child, then the last option would be to going for the tracheostomy. So as you can see, it was a large lymphatic malformation, which was involving all the neck area with all involvement of all the vital neck structures. The mass near the airway was excised, but unfortunately, we were not able to extubate the child and child ended up with the tracheostomy tube. We also did a bronchoscopy in this child and there were lesions which were involving the larynx and the vocal cords also. And we had to do a feeding gastrostomy also for this child to ensure the nutrition, because the child was not able to swallow properly. After around 3 months of age, we started the child on sclerotherapy. The child received around 3 sessions of sclerotherapy and responding well, but unfortunately at age of around 1 year, 1 month, he presented to us with a severe lower respiratory tract infection and succumbed to death, and we could not revive the child. So that was a team which was involved in the procedure. All our team of obstetricians, pediatric surgeons, OT technicians, anesthetists, and I'm really thankful for their cooperation and for the successful management of the fetus by performing the exit procedure. Now, in the second part of my session, I will just, in brief, I would like to have the management of, discuss about the management of the antenatal hydronephrosis, and as a surgeon, how we manage these patients who presented to us with antenatal hydronephrosis. So as you all know that it's a very commonly encountered condition, and almost 1 to 5% of all the pregnancy, we see that there are a wide spectrum of the urological conditions. But in spite of so much of studies and in spite of so much of literature which is available, still there is a physician uncertainty and the parental anxiety, because still we don't have a clear-cut definition, classification, and the grading system. And still there are a lot of controversies to define that which hydronephrosis is pathological and which hydronephrosis is a non-pathological. And what is now required is a uniform classification system and a standard terminology so that we can prognosticate these patients. 2015, a new term has been coined. Instead of hydronephrosis, the term urinary tract dilatation has been proposed to avoid any confusions. Now, as you all know, most of this hydronephrosis is a transient dilatation, but some of them can be pathological in the form of vesico-ureteric reflux and or true obstruction. And these are the two pathological hydronephrosis which needs to be diagnosed early so that we can avoid the renal damages. As a surgeons, we normally evaluate these patients by ultrasound, MCU studies, various nuclear scans, and for complex renal anomalies, we perform the magnetic resonance urography. Now, most commonly studied parameter in the evaluation and the prognostication of these patients is the anteroposterior diameter of the pelvis, which is taken in the transverse plane. So till now, most of the literature and the studies, AP diameters are the most studied parameters, and the numbers 7, 9, and 15 are important values for us, because anything between 7 to 9 is a moderate hydronephrosis, 9 to 15 is a 7 to 9 is a mild, 9 to 15 is a moderate, and more than 15 mm is a severe hydronephrosis during 3rd trimester. So this is how we normally prognosticate our patients, because if it's a mild hydronephrosis, only 10% of these patients, they will end up with some or the other form of interventions. If it is a moderate, around 40 to 50% of them land up with some form of intervention. But if it's a severe hydronephrosis, then almost 10%, almost 90% of these patients, they will land up with some or the other form of interventions. So this is how normally we prognosticate them depending on the severity of the dilatations. Now, as I mentioned, that urinary tract dilatation classification system has come up, and they are not just focusing on the AP diameter, but also on the dilatation of the calyces, parenchymal thickness, appearance of parenchyma, ureter, bladder, and unexplained hydronephrosis mass. So if any of these features are abnormal, then the risk stratification is done, and the fetus is labeled as a low risk or high risk. So if there is a peripheral calyceal dilatation along with the increased AP diameter with parenchymal thickness abnormality or appearance abnormality, if there's abnormality in the ureter or if there's abnormality in the bladder, then it is a case of increased risk. So these are the red flag signs which are very important, and one has to look for in these antenatal scans, which will help us in classifying them as a low risk or high risk group. Similarly, during postnatal period also, all these parameters are important to classify them in as low risk, intermediate risk, or high risk. A high risk will have an AP diameter of more than 15 mm with peripheral calyceal dilatation, thinning of parenchyma, echogenic parenchyma, abnormal ureter, and bladder abnormalities. So I will just discuss some few cases that who presented to us with antenatal hydronephrosis. Like this antenatal scan, 32 weeks, AP diameter is around 13 mm, and AFI is 9. So what are we going to prognosticate? How we are going to prognosticate the parents? We are not sure that is it a transient dilatation or it's a pathological dilatation. What is going to be the accurate diagnostic tool? How long we have to follow these patients and when we have to operate? So all these questions will come in our mind and also in the minds of the parents, which we need to answer. So as I mentioned that the dilatation is around 13 mm. So it is somewhere, it is a moderate hydronephrosis, and the risk of fetus requiring some form of intervention will be around 40 to 50%. The chances of resolution will be around 40 to 50%. But the most important thing is this finding should not be ignored. The child should be reassessed after delivery with the help of ultrasounds and the renal scan, and pregnancy can be safely continued till term. So postnatally, the child was fine, bladder was not palpable. We did ultrasound, AP diameter comes out to be 14 mm when the ultrasound was done after 48 to 72 hours. And we did ultrasound, and we did plan for an ultrasound and TTPA scan after 1 month of age, and we started the child on chemoprophylaxis. So this is how we evaluate these patients. Mild hydronephrosis, just follow them with ultrasound. Moderate to severe hydronephrosis, we start them on chemoprophylaxis. MCU can or may not be done. DTPA scan is required. If it's a hydroureter also, then the child has to be started on chemoprophylaxis and early MCU should be considered. Bilateral hydronephrosis, bladder outlet obstruction, and single kidney, one has to evaluate more aggressively. So coming to the indication of the surgery, if it's a severe hydronephrosis or if it is progressively increasing AP diameter or split functions are less than 40%, and there is a fall in renal functions associated with the parenchymal thinning, or if the child is symptomatic in form of a lump or recurrent UTIs, one should always consider for the surgery. So when we followed this child on with the DTPA scan, we found that we followed when this child with the ultrasound, we saw that there was a progressively increase in the AP diameter. And the DTPA scan also showed the deterioration in the renal functions. And so we advised them for the surgery, which is pyroplasty. Now, when we talk about the mild hydronephrosis, as I mentioned, we need to just follow them with the regular ultrasounds And most of these mild hydronephrosis, they can resolve by almost 1 to 2 years of age. Now, this is a very challenging and tricky situation. When you see an antenatal scan with bilateral hydronephrosis and hydroureter, and there's a bilateral echogenic kidney, a classical keyhole sign, very high possibility of posterior urethral valve, and there's also associated oligohydramnios. So whenever there is a bilateral hydroureteronephrosis or unilateral hydronephrosis, there is either a reflux situation, problem of reflux, or there could be obstruction at view junction, or there can be obstruction at the bladder outlet area. And this sort of obstruction and the reflux problem can cause obstructive uropathy or reflux nephropathy. And whenever you see a bilateral ureteronephrosis and a classical keyhole sign, we always explain the parents that this is a very tricky situation. The child will require a long-term follow-up. The obstruction needs to be dealt immediately after the delivery, and there's also associated risk of end-stage renal disease. So this child was 1.6 kg when born. Repeat evaluation revealed the same findings. The serum creatinine was 1.6. There's a classical dilated posterior urethra with a trabeculated bladder, and there's a left-sided reflux, as you can see in the picture. So this was a premature baby, 1.6 kg, and we did a cystoscopic fulguration of the valves, as you can see in this video. So what I'm trying to say here is that even for a premature babies, you have the miniature cystoscopes by which you can fulgurate these valves and can relieve the obstruction. But this is not the end of the story. As I mentioned, the kidneys are already affected, the kidneys are already scarred, and these patients needs to have a long-term follow-up with pediatric nephrologists, and they may even land up with the end-stage renal disease. Now, if the ultrasound is showing left-sided hydroureteronephrosis in a newborn baby and the renal functions are less, then the only option we are left is the diversion. That is, we need to perform a ureterostomy. So we can't do a ureteric implant surgery in a newborn baby. And in an obstructed system at the level of vesico-ureteric junction with affected kidney, we have to bring the ureter out, what is called as a ureterostomy. Reflux is again a very common problem which can lead to a scarring of the kidneys. And the indications are of surgery. Most of the time we manage them with a medical management with the uroprophylaxis. But if the child is symptomatic or if there is a progressive renal damage, then we have the options of either endoscopic injection or performing a ureteric implantation surgery. Now this child who is having a left-sided grade 3 VUR, having a recurrent UTI problem, we have left with the option of putting a Defects injection at the area of vesico-ureteric junction. So you can see that putting a Defects, this is a sort of an implant, which is a permanent implant. It narrows the vesico-ureteric junction and it prevents the reflux of urine in the kidneys, and it is especially very effective in low-grade reflux, grade 1 to 3 reflux. Ureter seal, again, a very common problem which causes the obstruction of the ureter and requires a very simple management, that is just the ureter seal incision. So there's a video, that's a filling defect on MCU, there's a ureter seal on MR urogram, and when you see the cystoscopy, there's a large ureter seal lying here, which is obstructing the ureter. And if it is an obstructed system with hydroureteronephrosis, the best option is to puncture this ureter seal so that the ureter gets deflated and the obstruction can be relieved. So this is the post puncture of the ureter seal ultrasound. We can see that there's a deflated ureter seal and reduction in the amount of hydroureteronephrosis. So to conclude, most antenatal hydronephrosis, they just need proper surveillance. Do not ignore hydronephrosis, even if it is a transient, because they needs to be observed, they needs to be followed. AP diameters 4, 7, 10 are important numbers. First 2 years of follow-up is very important. Every obstruction causes dilatation, but not every dilatation is obstruction. And it is very important for us to identify the high-risk group so that you can preserve the nephrons of the kidney. Thank you so much.
Thank you, Dr. Prashant, for such an
elaborate description of exit procedure and also about hydronephrosis. It's nice that you took only two things and elaborated on that, so that I know the hydronephrosis is very common. So we see in our practice also, and the obstetricians, they don't know what to do and they refer them to fetal medicine specialists.
True.
So in our place, we have a joint counseling with pediatric
That's
surgeons.
True. That's true.
So that is very good in a way that we can, at the same time, we can, both of us, both pediatric surgeon and we also counsel. So about the pediatric surgery, I think the best part looking at the fetal structural anomaly in the antenatal period, you can prepare the parents and you can prepare the doctors also, as you have very beautifully shown, to what is going to come. So they are also prepared and they know that they have to be in the hospital for a long time after delivery, and maybe you can do antenatal transfer also to a place where the surgery is available, so patient can be shifted. So these are the main things that are there. And one more thing about the structural anomaly is that some of them can be associated with chromosomal abnormality also, like duodenal atresia or omphalocele, although it is quite easily surgically correctable, but then that also needs to be explained to them when we are doing an antenatal counseling. Excellent, the pictures that you have shown and the videos, and very good. We have also done exit procedure in 2 cases, but we also had the babies couldn't survive, one of them 1 month, another only 15 days. So, but it's very nice to see.
Thank you so much. Thank you.
Thank you, Dr. Prashant. It was a lovely presentation. 1 or 2 things I would just want to add is that yes, these urological abnormalities can be definitely very, very challenging. And we all know that these children tend to land up into problems later on in the childhood, and they need a multidisciplinary approach throughout till the time they actually come out of it. So we see a lot of these end-stage renal disease children with lot of procedures being happening, like Mitternoff procedures or other things where either the bladder is the problem or the ureter is the problem or the kidneys are gone. So one good thing what I have felt in these last so many years is that at least pediatrics is one branch where this multidisciplinary team approach works very well.
That's true.
Especially pediatric surgeons, gynecologists, obstetricians and pediatricians, intensive care surgeons. Most of the centers, good centers which have the complete team, they work as a cohesive team. So I think that is one good part, and we are able to manage such good cases. And really nice presentation. Thank you very much.
Thank you, sir. Thank you so much.
So I would like to thank the chairpersons and the speaker, Dr. Prashant. It was wonderful presentation. Now, due to the lack of time, we'll be moving on to the next session, and which is about the fetal surgery. And I would like to invite the chairpersons, Dr. Amita Gupta, who is working as a senior consultant and obstetrician and gynecologist at Maharaja Agrasen Hospital, Dwarka. She has done her MBBS from LHMC and DGO from Safdarjung Hospital, New Delhi. And she has also taken basic ultrasound training, colposcopy training, and she is in the obs and gyne practice for past 20 years. Keen interest in obstetric ultrasound, colposcopy, and high-risk pregnancy. Welcome, ma'am. And next slide, please. So I welcome Dr. Akshata, who has been my colleague at Apollo also, and now we keep interacting quite often. She is currently attached to Indraprastha Apollo Hospital as a consultant fetal medicine, and she has a maternal fetal medicine register. She has been trained at maternal fetal medicine at KK Women's Hospital, Singapore, and National Examiner for the FMF UK Anomaly Certification Program. She is a member of Royal College of Obstetricians and Gynecologists UK and Treasurer Fetal Medicine Foundation. And she has received a Commonwealth Scholarship for Fetal Medicine 2014. She has lots of publication, WHO project and for fetal growth charts, and a multinational longitudinal study of ultrasound biometric measurements and estimated fetal weight, and numerous publications in peer-reviewed journals. And her special interest is in fetal therapy, fetal neurosonography, multiple pregnancy, and fetal growth restrictions. So welcome, Akshata. Now I request Dr. Amita to introduce our speaker for the last session. Dr. Anita Kaul.
Good evening, everybody. Thanks, Dr. Seema and AOGD, Fetal Medicine and Genetic Subcommittee to give me a chance and opportunity to introduce a well-known person, Dr. Anita Kaul. Dr. Anita Kaul is currently the head of Apollo Center of Fetal Medicine at Indraprasth Apollo Hospitals, New Delhi. She obtained her medical degree in 1986, Master of Surgery in 1991, MRCOG in 1996, Diploma in Advanced Obstetric Ultrasound in 2005, FRCOG in 2010, and FICOG in 2016. She's trained in fetal medicine with Professor Kypros Nicoldis at Harris Birthright Research Center in London in 2004-2006, and later in fetoscopic interventions with Professor Jan Diepers, Belgium in 2011. She has started the Fetal Therapy Center at Indraprasth Apollo Hospitals, New Delhi in 2011. She aims to provide treatment options and services previously unavailable in North India. Her main areas of clinical interest at present are establishing screening protocols which are relevant to Indian population in aneuploidy screening, preeclampsia, growth restriction, multiple pregnancies. She has been instrumental in introducing FMF certified training and quality assurance in obstetric ultrasound and has become co-convener of National FOXI FMFI ultrasound training program.
Thank you.
Well, I invite Dr. Anita Kaul for her talk in utero surgery. Is this a myth? Welcome, ma'am.
Thank you so much, Dr. Amita. It's really nice to interact with all of you. If only we get an opportunity at least online. And thank you so much, Seema. I really do appreciate the amount of work you put in, because I've seen the endless preparation at the back and also with Sabitha. So thank you. But the topic that you gave me, which you said keep it really, really basic, is what I've tried to do. So I thought that it would be nice to get like an overview of where our specialty is going. And this topic is perfect following Dr. Prashant's presentation, because there's the overlap. And this is how actually fetal medicine and in utero therapy came in, because really it was all started by the pediatric surgeons who got so frustrated by the fact that the postnatal outcomes were so bad in a variety of things that they thought, well, can they move the timeline a little bit forward? For us, it started with fetal blood transfusions, and then the pediatric surgeons came in with all these open procedures where they thought, which is, still not there with us, but it's something for us to think about, is that where you do a hysterotomy, sit there and identify the defect, repair it, and close the uterus and move forward. Then, because the Achilles heel of any kind of in utero procedure is the fact that you can go into preterm labor, and at open fetal surgery, the risks of preterm labor were practically 50%, much higher, that the fetoscopic procedures came in, that let's try and do it with a smaller scope, smaller everything. And then, of course, the image-guided procedures came in, and now we have instruments coming into the specialty, like, for instance, radiofrequency ablation. So it's been around and it's changed, but the sort of basic technique is either using fetoscopic procedures or using ultrasound-based procedures, or actually just doing open fetal surgery and just doing a hysterotomy and checking things. So I thought that if you go from head to toe, then actually it's a myth. There's no in utero surgery for head and face. So there's just, we absolutely do not think that there's anything you can do there. So we are stuck. Certain procedures are there in India, especially in the south. So Dr. Nageshwar Reddy and team, the Amrita Kochi people, they are looking at interventions for the heart, because if you go from head to the thorax, there's a lot of things you can do in the thorax. So this is a reality that is definitely not a myth. Basic physiology is, and basic principles of heart surgery is that you want to give this child a biventricular function. And whenever you have an organ which is not being used, for instance, if there is some problem in the outflow tract of say the left ventricle and the blood cannot be pushed out, what happens is that where you would expect that it would balloon out, it is the contrary, because if an organ is not used, it kind of shrinks, and you may end up having like a single ventricle. So in these situations where it looks that there may be a possibility of a single ventricle, people have thought to do the things that they do in the pediatric life. So in the pediatric, they try and do ballooning so that they improve this forward flow. And they use these kind of balloons which go in and they kind of cross the valves. And this is a procedure which they try to reproduce in utero life. These images are from Amrita. My colleagues send them across, but essentially it's ballooning across the valve. It's not an easy procedure to do, and it's not something that we can completely reverse and completely make it like a biventricular heart, but there is going, everyone is trying. So all these are images from Amrita where they kind of showed this needle procedure trying to grow across the valve and ballooning. For some reason, these videos are not playing. But this is that pre-procedure. You can see very clearly there was just blood on one side, and post-procedure, they did get perfusion across both sides. So there's a lot of work coming in, and I hope our pediatric cardiologists also eventually work towards this. The other things that can happen in the thorax, where again in utero treatment is a reality, is CPAMs. I mean, CPAMs, this is one which had recently to us. So you can see that the heart is really pushed to one side, and there are these huge cysts. And it is understood that if you drain the cysts and you allow the lungs to grow, because the basic point of all lung therapy is to allow the lung to grow. So in this case, if you remove this and if you continuously remove it, it would be better. So in this case, that's what we try to do, is we try to aspirate all the fluid, and you can see there was enough of lung tissue left, and we were very hopeful that the couple would continue on, and suggested that the next thing that we need to do is shunt, and we advise shunting. The shunt that we use is something called the rocket shunt, and there are special sort of instruments for that. I was illustrating, they just wanted to do needle procedures. They weren't very happy. But if you have patients, and this is a case of pleural effusion where we put in a shunt, essentially this is the shunt over here, and essentially it's a little plastic double ended tubes where one end goes inside the cyst or the fluid, and the other end comes out the other way. So this is something that can be done and can be offered. So again, this is a reality. The other things which is a reality is if you have something like a bronchopulmonary sequestration where the blood is coming straight from the aorta. It's where the supply to one particular part is straight from the aorta. So the general principle over here is to wait for hydrops to occur. It may or it may not. If it does, then we use laser, and we use interstitial laser and burn this area so that we can just stop the feeding vessel. So again, for these kind of cases, again, it is a reality there. The diaphragmatic hernias are the other things, and this is something that we don't do, but as Dr. Amita had mentioned, Professor Jan de Prest, who is one of the pioneers of fetal surgery, I mean, the thing that he's particularly a pioneer of is diaphragmatic repairs. So for us, our main thing using ultrasound, our job is to decide, is it a mild or a moderate or a severe or an extremely severe diaphragmatic hernia, because we try and prognosticate that when the pediatric surgeons sit there and repair the lesion, how bad are things going to be? So if it is mild, then really expectant management is good enough, because these babies on the whole should have a good outcome. There was a big trial to see as far as moderate is concerned, because we thought this was the total trial where it was thought that in the moderate group, do they benefit by having a fetal procedure? And then this trial, which was, the results came out about 2 months back, showed that actually whether you do expectant or whether you manage them with feto, it doesn't really make a difference. But what we realized was that in severe cases, intrauterine fetal surgery does make a huge difference, and the survival rate is significantly more. So but there are special instruments that you need to use, because the basic point of this technique is to close the trachea. The logic is that what the diaphragmatic hernia does is it doesn't allow the lungs to grow. So if you sit there and block off the trachea and allow the fluids within the lung to accumulate, these themselves would push out the lungs and allow it to grow. And therefore, your risk of pulmonary hyperplasia is much less. So the survival is much more. So again, this is Professor Jan de Prest's video, whereby you can see that you're doing exactly, that's why I enjoyed Dr. Prashant's videos so much, because all these endoscopic procedures, they look very nice. There's hardly a lot of vision just because it's so small, but essentially you can see that the scope is going right inside until it reaches past the vocal cords, until it reaches the throat, and then this balloon, which is a special balloon. I mean, it's not that you can go and pick it up. This balloon is kind of inserted inside, and then it is plugged in. Now, the key point about doing fetal procedures is that it's equally important that you need to remove it, because obviously if the child is born with this balloon inside, it'll die. And that is how they've lost babies, just because they died in the neonatal period, because the balloons couldn't be removed by the neonatologists in time. So once the balloon is there, that's put in. And so the principle is that once it has, you leave it inside for 6 weeks, because it's thought that 6 weeks is good enough for the results to come in. Then they go inside again, and with these special sort of clippers, just pull it out. Now, this is where the morbidity of the procedure comes in, because you need to go it twice. And this is where all the work is happening to see that, is it possible that you remove it as a needle procedure, and they're trying to make it like magnetic, so that if you go into an MRI, can it burst? Can it burst? So a lot of research is happening as far as this is concerned. So this is a slide of Professor Jan de Prest when he was presenting his talk, and the results of this total trial, which was like a life work for him. And one can see over here that severe diaphragmatic hernias, the survival to discharge was much higher than if you did nothing. Moving on to GIT and renal, we don't really have much in terms of in utero surgery, because generally the outcomes are good. And again, as Dr. Prashant showed you, renal issues can do well, and so we would not interfere. The problems are there in the lower urinary tract, or the so-called Luto cases, because here we really don't know what's the best thing to do, because on ultrasound, we can't identify, is it a posterior urethral valves and will benefit by fulguration, or is it urethral atresia itself? And therefore, there has been an attempt that one puts in a scope, does a cystoscopy, a fetal cystoscopy, to try and identify, is it an atresia or is it a valve? And then if indeed it is a urethral valve, then maybe fulgurate it at the same time. We've tried to do this ourselves and along with the pediatric urologist, but at the moment, to be honest, we are not so chronic renal damage. We've never been able to convince a patient actually to undergo it. And so far, at least for us, our experiences have not been particularly good with these procedures. So you can have a vesicoamniotic shunt, but the problem with this is that because if the shunt keeps draining, you have a floppy bladder. And then afterwards, to get it working like a normal person's bladder becomes actually quite difficult. So I think the pediatric urologists find this a challenge. And the laser and the fulguration is still a new procedure because there's potentially issue of perhaps causing a fistula and so forth. So the therapy is still evolving as far as this is concerned. The new things have happened with the myelomeningocele, and this has happened because this is a very common neural tube defect. And the research for this came again from the US, because in the US they found that there were maybe like 200 women who wanted to offer, they didn't want to discontinue a pregnancy if there was a myelomeningocele, they wanted to continue. And they felt, and this is the difference between India and the Western countries, especially something as a country as rich as the US, that just because they had 200 women per year who wanted to have a surgery for their baby for a neural tube defect, they thought that it is something that they must address, and it is something that they must sit there and kind of research about. So they looked, this was the MOMS trial, and it had to be stopped just because the results were so good, and they felt that it was unethical to continue a trial where it was seen so clearly that the need for ventricular shunting had come down, the neurological effects had come down, there was improved ambulation, there was also reversal of the hindbrain herniation. So they felt that how can you justify, and I wanted to play this video for you because this is where the original research came in, and this is a YouTube video, but I really liked
Spinal
it.
cord.
Because I think that we need to know that things are happening, and eventually with us, we think our resources
Fetal surgery
in India
for
are
spina
so
bifida is an incredibly complex procedure. At Children's Hospital of Philadelphia, where the surgery was developed, a team of more than 20 people are in the operating room. They include up to 4 fetal surgeons, 1 neurosurgeon, 2 anesthesiologists, a maternal fetal medicine specialist, a fetal cardiologist, and specialized nurses. They have performed this procedure more than any team in the world. Before surgery, the mother receives deep general anesthesia. Fetal surgeons make an incision across the mother's abdomen. The maternal fetal medicine specialist uses ultrasound to determine the position of the fetus and the margins of the placenta. The uterus is then opened with a specially designed uterine stapling device that controls bleeding, and the fetus is positioned so the spinal defect is visible. The fetal cardiologist monitors the baby's heart as the team closes. The neurosurgeon removes the sac on the baby's back that covers the opening in the spinal cord. The sac is a thin membrane filled with fluid. The neurosurgeon and the fetal surgeon then close the defect in multiple layers using a lacing technique. First, the muscle layers are closed over the defect. Then the skin is closed over the muscle layers. This ensures a watertight closure. The mother's uterus is closed in multiple layers. Then her abdomen is closed and she is returned to her room. The pregnancy then continues until planned delivery at 37 weeks gestation. Most often in our special delivery unit, created for moms carrying babies with birth defects.
you can see that, there are parents who may wish this. And I know at some point a team had come to India and they were trying to establish in India. So I don't know how far the program has gone, but I do believe that at least in some hospital in India, we should develop this program. They may not also, they're trying to make it like a laparoscopic procedure so that, one doesn't open out, but there's a lot which is happening in here. Miscellaneously, I thought that I'd cover placental chorangiomas, because this is another one where you can do a needle procedure. So this particular one, which had gone into practically high drops, we needled it over here and lasered it. This one, which was a bit more recent, was the vessels were too big and it was not possible. I mean, we felt that this needling would not be a good thing for this particular case, and blood transfusions were offered for this particular case. This was an interesting case some time back where we could see the amniotic bands around the wrist, and there were some also coming up here. And we thought that we would see whether we could, break them or cut them. But what happened with the patient was that the patient said that we thought that at least let's do a diagnostic and see how we go. And this is the vitoscopy images. And what happened at the time is something that we didn't realize, because we saw the hands closed. And what we didn't realize was that, sorry, I'll just close this. What we fingers were so badly amputated that the parents got a little bit demoralized by the fact that they couldn't, the hands were worse than they anticipated. So as you can see over here, there was hardly anything. So these fingers are amputated and that's there. But nevertheless, we thought that let's see if we can release some of these bands. And the aim is that these bands are so entrenched inside the wrist that if you burn them, we hoped that it would come out. But actually that didn't happen, because no matter how much we burned, and you're burning on the flesh, but if as the video continues, you'll realize that this is a really edematous hand, and that's one of the problems with amniotic bands. They cause so much edema that it's really difficult to see where the band is to burn it. And this other one also, so you can see the hand is really edematous. And then subsequently, even here, we tried to sort of break it and use manipulation and use, use sort of laser to burn it. So even though this was released, there was still too much. And then these parents, so even though we kind of released the big one, we were unable to release the one actually on the wrist. And then the parents chose not to continue with the pregnancy. But this, so I think that now, if were I to do this procedure again, I think it's better to do a second port and use scissors. But this all comes, once you've done some, then you can sit there and realize that these are the problems that have arisen, and these are the things that you need to do. So because I had very little time, and because I thought all of you would be familiar with the surgeries associated with multiple pregnancy, I have not really covered that. But essentially, the multiple pregnancy surgical options are the sort of backbone of in utero fetal procedures. So just to conclude, I do think it's a reality. I think the learning curve is very long. I think the cases are few because the obstetricians tend to, because is it lack of awareness, or because they think that they're a young couple, or do they think I don't know, but there's not a lot of encouragement for actually fetal procedures. And then, so they're not encouraged to actually go through. What we find now in our cases are it's the young people who are sort of financially independent. They're the ones who kind of take decisions and they come for it. Pre-labor Achilles heel of fetal surgery, and this is something that we're very conscious of, and that's something that we're always thinking. And what I believe, because I do believe now, having done this for such a long time, I think that it's not as easy as, you know, today you buy an instrument and tomorrow you sit there and do the procedure, because really you're saying that you are successful when this baby is born and when you made sure that it has had no problems at all. So just doing a procedure and then maybe 3 months later she going into preterm labor, I feel you haven't really achieved anything, because you've added prematurity to these problems. So I do think that we should encourage in utero surgery, and it's very much a reality. So I thank you, Seema, for giving me this talk, and I enjoyed the session, and I was really pleased to see Sabitha. Sabitha, hi. I'm trying to see you.
Yeah. So actually, so now we realize, yes, that it's not a myth. There is a reality also to a fetal surgery, right? And you are doing quite a, a number of them. So I think it's a time that we should start because most of us are not aware, and that's why probably the referrals are lacking. Because if you don't know how will, so that was the basic idea, that you introduce this topic to us so that we can start.
Can I get them to stop my share so I can see you guys? Saurav or Shivam? Okay, thank you.
So Vandana or Dr. Akshata, would you like to add some?
Yeah.
Yeah.
Sorry, we both are sitting quite close by. So true. Like ma'am said, I still remember the first day that long back, 11 years ago, when we did the first in utero laser, and we were all excited. And we had Prof. Jan Deprest, who had come down to tutor us. And since then, we've come a very long way, not just working on the placenta, trying to do the laser anastomosis, but really going on to doing in utero fetal surgeries. I mean, you say necessity is the mother of all inventions, and true, women who are committed to a pregnancy or not allowed to terminate a pregnancy, that's where a lot of work has been done, and we've come a very long way. And it was 2016 when we had the first, it was very heartening to read where Dr. KNR from Hyderabad had his first balloon valvotomy baby, in utero balloon valvotomy baby, celebrate its first birthday, doing very well. So we know we've come a very long way, and it isn't a myth anymore. And like ma'am said, I think there have to be a few centers that need to be identified where these fetal surgeries can happen. And I hope sometime soon that will take place. Dr. Vandana ma'am, do you?
Yeah, it was nice listening to you, Dr. Anita, and I think I'm seeing you after a long time. Can you see me?
We can't hear you.
You can't hear me? Can you hear me now?
We can hear you, ma'am.
Yeah. So it was great listening to you, Dr. Kaul, as always. Extremely entertaining and extremely lucid. I think the point which she made in the end, that it's the long-term outcomes which matter to us, especially in India, they really matter to us. So whenever we offer any fetal surgery program, we should have our data for the long-term outcomes clearly chalked out and use them in our counseling also.
So thank you, chairpersons and the speaker, Dr. Anita Kaul. And now I request Mr. Shivam. Yes. So now I request Dr. Sangeeta to give us vote of thanks. Dr. Sangeeta, are you around?
No, ma'am.
Okay. So at the end, I would like to thank all our faculty, the chairpersons, the speakers, for finding time for our conference. It has been a long conference, but it was a wonderful conference. So thanks all the faculties, experts, and the chief guest, and the guest of honor, and so everyone. And I would also like to thank to G and Lilac Insights for sponsoring this program. And last but not the least, the Mr. Shivam and Mr. Saurabh for helping us out in all these this. And at the end, I would like to thank all delegates for making this program a success. So thank you all. Okay, Shivam, we have done.